based in the health emergencies program of the World Health Organization, WHO. Actually, she is the technical lead of COVID-19 response and the head of emergent diseases and zoonosis unit at WHO. She was born in New Hartford, New York, but I'm not telling when. Don't worry about that. But actually, the important is that in New York, she got at Cornell University her Bachelor of Sciences degree, and then 1 year later, she received the MSc degree in epidemiology already at the Stanford University School of Medicine. And some years later, in 2009, she got a PhD degree in infectious disease epidemiology from the London School of Hygiene and Tropical Medicine, when she wrote her thesis on avian flu in Cambodia. Very interesting since then. In April 2009, she began working as a technical consultant to WHO in its Global Capacities Alert and Response Cluster. So she's getting into WHO first by consultant and then by a leader. From 2015 to 2017, Maria was the head of the Outbreak Investigation Task Force at the Institut Pasteur Center for Global Health, conducting field research into surrounding zoonosis, respiratory viruses, as well as emerging and re-emerging viruses such as Zika, Middle East Respiratory Syndrome coronavirus, MERS, Ebola, and other emerging diseases. Actually, by that time, in 2015, we met each other for the first time when she was at the Institut Pasteur in Paris, and we had the opportunity to work together in one European Union project called Zika Alliance. By that time, I learned how effective she was in capturing central ideas of what was going on in respect to the Zika global epidemics and putting these ideas into conceptual, crystal clear sentences in the project, which, by the way, has been funded by the European Union. Should I say that, for me at least, it was a very nice experience of co-working, really pleasant. And since then, although not seeing each other so frequently, we remained in contact, and much more than that, we became friends. In March 2017, she became scientist technical lead on MERS at the WHO, and she's currently, as I said before, the head of the Emergent Diseases Zoonosis Unit in the WHO Health Emergencies Program. And lastly, as well as I could, retrieve this from the internet. In late December 2019, Maria was in the US when she heard about the cluster of pneumonia of unknown etiology in China. This immediately raised the bells for her and for the WHO team. Reacting to the emergence of COVID-19, Maria was a part of the coalition of different WHO teams that worked together so that to organize the non-information at that time. She then spent 2 weeks in China in February 2020 to better understand the COVID-19 pandemic and also to understand how China was trying to control the virus. Within 2 weeks of this cluster notification, WHO published a guidance on how to respond to COVID-19, particularly based on prior work such as Maria van Kerkhove's experience with MERS. Then, as COVID-19 spread out the globe, Maria became the spokesperson for WHO communications in a weekly, sometimes daily basis. And as she told me some time ago, some minutes ago, this was not free. I mean, it was sometimes a bad experience in terms of really threats that she received. And this is serious, very serious. But anyhow, in this role, she faced the issue of striking a delicate balance between conveying the severity of COVID-19, but at the same time remaining calm, because she did not want to be accused of being alarmist. Actually, what happened was the opposite. She became a global star. Seriously, the work of disseminating true news was and remains one of key importance to the world in terms of providing peoples on Earth the importance of science for the well-being of mankind and actually the life in the whole planet. Having done all that, as well as many important scientific publications, more than 100 in the PubMed database can be retrieved, Maria is only 45 years old, no more than that. Really amazing, I think. Well, Maria, on behalf of the Brazilian Academy of Sciences, I thank you very, very much for accepting the invitation and sharing with us this at least intense experience in leading the global efforts to cope with COVID-19 pandemic. Please come to the stage. The mic is yours.
Thank you. Sabino gives good hugs. Thank you so much. Thank you for that really kind introduction, and I'm so thrilled to be here. This is one of my first, can you hear me okay? This is one of my first trips out of Geneva since December 2019, and it was so important for me to come here, so I thank you very much for the invitation. I think I said yes immediately when he asked me, and at the time it was a virtual, I think it was a virtual invitation, but I'm really, really thrilled to be here in person. I'm going to give you a bit of an overview of where I think we are in this pandemic and where I think we're going, and outline for you how WHO is thinking about how we end the emergency of COVID-19, not just in some countries, but in all countries. I have to start with where we are. I'm going to turn this way so I can see my slides. So this is the global epi curve, as I'm sure you've seen many, many times. What you can see here is incidence by week, and each of the colors represents a different region of WHO. With the emergence of Omicron, which is the latest wave that you see here, we literally had to redraw the figure because the scale was so different in terms of the numbers of cases. You can see a decline in cases in recent weeks, but I'll talk a little bit about this because this is in the context of certainly some countries passing their peak of Omicron, but most countries have significantly altered their testing strategies, and some countries have completely stopped investing in strategies and in fact are dismantling systems. What you also can see from this graph is the black line there, which represents mortality. And you can see a sharp in mortality over time, and this is what one would expect when you have several safe and effective vaccines, which, if you remember in the beginning of this pandemic, I think we forget how astonishing it is that we actually have so many safe and effective vaccines. WHO released mortality estimates today, which you may have seen in the news, suggesting that while we have a cumulative total of more than 6.2 million reported deaths, that figure is likely 3 times higher. And those are direct deaths. So 6.2 million reported deaths, and we know that's a gross underestimate, as is the cumulative number of cases of 500 million cases to date. So, of course, the global picture is only one way in which we can look at this, but it's very different in terms of the trends by region, very different in terms of each country's experience, and also at subnational levels. But the trends are quite different. And on this slide, which if you've seen me present, I always use this slide, the scales are very different in terms of cases and in terms of deaths. But there's different patterns that you can see on the slide here. And a lot of this has to do with the way in which which strategies countries adopted. But what concerns us right now is our ability to really track this virus. And I'll spend a little bit of time talking on this because testing strategies have significantly changed in recent weeks and recent months. And we know that testing rates have plummeted. This does not allow us to really, we know monitoring cases is not a great indicator, but this is what we have at a global level. If I could show you graphs of hospitalization rates, ICU rates by vaccination status, by underlying conditions, I would, but I don't have that level of information from all countries. On the left-hand side, on the right-hand side here, excuse me, are some testing trends by region. On the right-hand side is a figure of detections and reports of Omicron by sequences that were supplied to GISAID. And what you can see on the graph is a sharp decline in the actual numbers of sequences that are available. Now, some may say you have less sequences because there are less cases being detected, but in fact, what we think may be happening is that we don't actually have tests being done, and you can't sequence those who you don't test. I spent yesterday in Brasilia at a lab expo, which was such a wonderful experience for me, listening to all of the different labs across Brazil and how you've expanded your testing and your sequencing from 3 labs to 27 labs. And that is such a triumph in terms of investments. What we hope to see is that investment be sustained, but not just here in Brazil, across the world. And this is really at threat at the moment. But every country is facing a very different situation of COVID-19. And there are a number of factors of why that is. We're all dealing with the same virus. We're all dealing with the same variants. There may be different proportions of those variants circulating at different times, but there are a number of factors of why countries are in different situations, why some countries are able to say, we're finished with the emergency, and why others are not. These are some of the factors that we consider and that we have to address as a global organization. So it has to do with the current and the past strategy of dealing with COVID-19, the current epidemiology and the circulation of the virus, looking at population demographics and risk factor severity among the population, looking at population level immunity from past infection and or vaccination. Seroprevalence right now across the world is very, very high, but of course we are into the 3rd year of this pandemic, and understanding immunity and the complexity of immunity still takes a lot of research, and I'm very grateful for all the work that you are all doing on that. Access to life-saving tools, but not just access, the use to implement the strategies, the use of the tools, and the ability to adjust. We've really seen countries struggle with adjusting to the use of these strategies. We've seen a pendulum swing of all or nothing constantly, and we're still dealing with that right now. And of course, one of the biggest issues we've seen in this pandemic is, let's say, a lack of public trust, societal engagement, and unrest. So there's a couple of examples of this, and if we look at some of the complexity of what's happening in individual countries, here's some examples of Western Europe, where we have high vaccination coverage and incidence of prior infection. And if you're looking at case detection, patients in hospitals, patients in ICU, and death, what we try to look at is not just vaccination coverage, but who in that coverage is missed. So for example, if you look at mortality in any country, and this is consistent across any country, look at the vaccination coverage in that population group, over 60, over 70, over 80 years old, with underlying conditions. And you'll actually notice, you will note that they have either had not the full course, they've had 1 dose, they've had 2 doses, they have not yet had 3 doses, or they haven't had any. Another example is in Eastern Europe, where we have low vaccination coverage among older populations. And what you can see, again, consistently in the data is that we see higher levels of mortality. Another example where we have moderate levels of vaccination coverage, but we have a high incidence of prior infection. We have a global study where a global effort where we're called the Unity studies, which is trying to standardize the use of seroepidemiology in this pandemic. And there are thousands of studies that have been published on seroepidemiology looking at different rates of seroprevalence, mainly prior to vaccination, but now once we've seen vaccination and coverage is really high. But if we look at South Africa and each of the waves that they've had very little vaccination coverage up until recently, where that's starting to take off. And each of those waves with the ancestral strain, they've had Alpha, they've had Delta, they've now had Omicron. In purple there, you see different sublineages of Omicron. And we're now starting to see an increase in BA.4 and BA.5 in South Africa. South Africa, like Brazil, is an incredible, does incredible surveillance and incredible research. We as WHO have been extremely grateful to work through them through our technical advisory group for virus evolution, and sharing in real time sequences and studies that are ongoing. And the same thing with several institutions across the world. Korea is another example that followed a really, almost a zero COVID type strategy, but really strong on suppression. I've spent quite a bit of time in Korea following the 2015 MERS outbreak. As Savino mentioned, I was the MERS focal point before this pandemic began. And in one country, I draw a lot of lessons from my time in Korea, because they had an experience of MERS with one exported case or one imported case in 2015, resulting in an outbreak of 186 cases and 38 deaths. The whole outbreak lasted maybe 2 months, maybe 2.5 months. There were more than 70,000 people contact traced and in quarantine at one point in time. It involved over 70 hospitals and had an economic impact of $8 billion US. And from that experience, Korea completely changed and modernized and updated their public health system. Changing the workforce, investing in workforce, making sure that institutions like Korea CDC, for example, had the authority to make decisions when outbreaks happened. Really modernizing what they did. And that experience was heavily drawn during the COVID-19 pandemic there, where in the beginning, a lot of people thought, well, this is just like flu. And for flu, you deal with it with a vaccine. But with this virus, and in particular, I was with a very senior official in China in February 2020, where we were watching what was happening in China, not just in Wuhan, but in other cities across China, and looking at how contact tracing, looking at how, and I'm not talking about lockdown, I'm talking about contact tracing, isolation, clinical care, quarantine, actually could prevent onward transmission. And in the beginning, Korea adopted that when they were having their outbreaks, and they changed the course of the pandemic in their country. But now they're seeing outbreaks of Omicron, because Omicron is so transmissible, but they also have high levels of vaccination coverage. So they don't see the same level of mortality as other countries are seeing, because vaccination coverage is so high in those at-risk groups. So we right now have the power to take the disease and death out of COVID-19. We just have to use it wisely. So there are a lot of drivers that are driving impact and transmission. So on the right-hand side, we have drivers of transmission. On the left-hand side, drivers of impact. And I put this up, and I use this a lot, because a lot of people say, well, it's just the variant, or it's just the vaccine, or it's just one factor. And it's complex. What I have learned in my public communication, which was not part of my job description, I have to say, this was never part of the plan, ever. It's really complex to explain what is happening, because there are so many factors that this virus takes advantage of. So we have virus evolution, we have these variants, and each of these variants of concerns are more transmissible. The question of whether or not we have more immune escape, or they're more or less severe, is uncertain, but they certainly have an increase in transmissibility. But we also have a lack of immunity. We have a lack of access to vaccines. And the use of these vaccines around the world is highly diverse and quite grotesque if you break it down. We also have waning of immunity over time, certainly from infection, because these vaccines were developed to protect against severe disease and death. They were never intended to prevent all infections and all transmission. They're doing a pretty good job, but their main role is to prevent severe disease and death. We have the inconsistent use of public health and social measures. In some countries, and countries are now in a different state, but when Omicron was raging, many countries just lifted everything. And for the life of me, I still can't understand why some countries just forgot how to use masks indoors or on public transportation when we know that they work. We now have ample data to show that they work. We didn't in the beginning of this pandemic. We also have misinformation, disinformation, and politicization undermining the effectiveness of these tools. And I, for one, have never, ever seen anything like this on this scale. Prior to this pandemic, every time I gave a talk, I would talk about my experience in outbreak investigation, and I would say, in every investigation, the science got smaller and smaller and the politics got bigger and bigger. But this is something I don't think any of us have ever experienced before. You can have the best laid plans, you can have ample evidence and science, but if you don't have that strong leadership, if you have politicization, you cannot mount an effective response. And we have seen this in almost every country. There are similar drivers of impact. I won't go through all of those, but there's a duplication on both sides because these factors not only drive how this virus circulates, it also impacts how the mortality and morbidity and mortality, the effect on people's livelihoods, on the economies as well. So let's talk just a bit about these variants. So there's much more expertise in this room and online than I have in this area, but I am so grateful to work with scientists around the world in tracking virus evolution. We established a virus evolution working group in June 2020 because we knew how important this would be. We formalized this into a technical advisory group now to advise us on these mutations and the combinations of mutations and what each of those means in terms of transmission, severity, immune escape, and our impact of our interventions. And the virus continues to evolve. Omicron, it's so different than what we were expecting as we were monitoring sublineages of Delta. But of course, this was on the radar that something would come out of left field, let's say. But Omicron itself is continuing to evolve. We also have recombinants. Because Omicron is so different in terms of its profile, its mutational profile, we are able to pick up these recombinants more easily now. Since the beginning of this pandemic, I think we have been tracking 11 recombinants. We have BA.1 and BA.2 now. We have a Delta and an Omicron sublineage recombinant, but there will be more. Luckily, these haven't really taken off yet, but again, this is something that we need to prepare for. The other thing that we worry about is the circulation of this virus in susceptible animal species. We know there are a number of animal species that are susceptible to SARS-CoV-2 infection. We had the cluster 5 variant, if you remember, from September 2020, which came from mink. The mink were infected from contact with humans. There was some transmission within the mink, and then the cluster 5 variant was detected again in humans. That virus did not take off, luckily. That was in Europe. But we worry that we will now start to see new animal reservoirs. And we have a new animal reservoir in the white-tailed deer in North America. But this remains a risk. With this level of circulation of this virus, and in particular with Omicron, we could start to see more circulation in animals and back into transmission back into humans again. So how do we deal with this? So following the report of the cluster of pneumonia of unknown etiology, and I was in the US at my family's house in December 2019. In fact, it was the last time I was at my family's house. We still haven't been back yet. We will go this summer. Within a month of that, and within a few days of Dr. Tedros, our Director General, announcing that we were facing a public health emergency of international concern, which is the highest level of alarm WHO can announce with international health regulations. And a lot of people don't understand what that means. A lot of people were waiting for WHO to declare a pandemic. We don't declare pandemics anymore. We declare an emergency at an international level so countries can take steps to prevent us from getting to the point of a pandemic, if that's even possible. So there's a lot of misunderstanding about that. But within 4 days of announcing a public health emergency of international concern, we issued our first strategic preparedness and response plan, which was basically outlining what countries needed to do, what partners needed to do to deal with this virus. We've updated that several times, and most recently, a couple of weeks ago, we've issued the latest one, the third one. And what we're trying to do is adjust the strategy, taking into consideration the complexities that all countries are facing. We realize that countries want to be done with this. I think all of us in this room would like nothing more than to be done with this pandemic and done with this virus, but it's not over. And it really is our responsibility to make sure that we keep up with this, but we recognize the challenges that all countries face. So what we're trying to do is optimize the national strategies and the response at a global level, at national levels, with two major objectives. On the left-hand side there is to prevent, diagnose, and treat COVID-19 disease, really reduce morbidity and mortality and the long-term consequences. And this includes post-COVID-19 condition or long COVID. But that's not enough. We can't just focus on morbidity and mortality. We also have to reduce transmission. And so this is about making sure that we protect individuals from exposure, particularly the vulnerable, and particularly those who have not been vaccinated, and reduce the risk of variant emergence. We cannot focus on one without focusing on the other. It's a false sense of security if we only focus on one and not the other, because we don't know what will happen with this variant, with this virus. So we are looking at different types of planning scenarios and needing to be prepared for any eventuality of the virus itself. So we have a base case scenario, which is really sort of our operating model of what we think will happen. Certainly the virus will continue to evolve. We expect severity, the impact of that, to be low or to be lower because we have tools, because we have vaccination, we have population level immunity increasing over time. And so we could see less and less severe outbreaks, but we will see outbreaks among those who are not protected. And we will see those, or if we have new birth cohorts. We think we may start to see some seasonality or some seasonal patterns in the temperate regions because it's a respiratory pathogen, but we are not seeing that yet. A lot of people really are just craving the predictability like we have with influenza or seasonal influenza. We don't have that with this virus yet, and so we don't have an opportunity to take a break. We have a worst case scenario where we have a more virulent and a highly transmissible variant that emerges, where our vaccines are less effective. And we will need to have a significant revision of a composition of the vaccines themselves, and we will need to boost, particularly in vulnerable populations. And that's the worst case. We also have a best case scenario where future variants are less severe and the protection remains. So we won't need to have the periodic boosting. What we don't have on the slide is a fourth scenario that we have, which is a reset, which is essentially a virus that's so different that we have a global susceptible population. The likelihood of that, of course, is low compared to these other scenarios here, but we have to prepare for that. And any future scenario has to take into consideration management of post-COVID-19 condition. I think some countries are really just starting to recognize what a burden this is. There's some really good studies that have come out looking at cohorts of individuals, showing very significant cardiac conditions, conditions of the brain, conditions of the lungs, and I don't think we really quite understand this fully yet. So in the adjustment of our strategy, we're looking at these 5 pillars of activities in the integration of this work across strengthening surveillance, laboratory work, and using the data in terms of analysis more strategically, having strong public health intelligence. On the upper left here, looking at vaccination, looking at the tools and the best use of those tools with engaged communities, empowered, engaged, informed communities. Also ensuring that we have safe and scalable clinical care, not just for COVID-19, but for all diseases that individuals face, and making sure that we have a protected workforce, a respected, a protected, and a trained health workforce with adequate infection prevention and control, and we have resilient health systems to deal with the surge and the changes in the needs and the changes in the use in healthcare systems. And we need to make sure that we further research development and we have equitable access to life-saving tools. And all of this, of course, needs coordination. So we need an integration of these different systems. And we're thinking about this for COVID-19, but also for the future. So these are some of the major areas of work that we're focusing on for surveillance. Again, we're really seeing countries cut back on surveillance activities. We're seeing a defunding of many of the surveillance systems of the workforce. Many of the workforce are being laid off. Testing strategies have cut drastically. The use of these tests, sequencing has dropped tremendously. And this makes us blind to this virus, blind to the trends, blind to the virus evolution, and we're not in a good position to really anticipate what may be happening. And so we need to make sure that this is maintained. In terms of vaccination, I'll talk about this in a minute. We have a goal of 70% of all populations in all countries. And within those 70%, 100% of at-risk workers and 100% of individuals who have underlying conditions. Making sure that we use public health and social measures strategically and that we deal with this infodemic that all of us are struggling with at the moment. So vaccination coverage is far lower than it really needs to be in some countries, particularly in Africa. So scientifically, with the advancements of the vaccines that we've had for COVID-19 and the further development of future vaccines for COVID-19, that's been a scientific triumph. And I have to say, one of the silver linings for me in this pandemic has been the incredible global solidarity of scientists and collaboration, which is built over decades. And that trust, and you represent that in this room and online. And as someone who now works at WHO, we rely on you for that information and to work with us. I had someone say to me the other day, and I think I said this yesterday, someone said to me, how big is your team? And I said, thousands. And they said, what do you mean thousands? I said, well, thousands. I mean, first of all, we have incredible workforce at WHO at the 3 levels of the organization, but I am fortunate to work with scientists around the world, academics, researchers, experts, that come at the drop of a hat when we ask people to come together and provide information, share information, advise us so that we could get the best guidance out there. So my team, so you are all part of my team, I guess. And I'm very humbled and grateful for that. But we have, while we've had the scientific solidarity, we have not had that in terms of their use. And so not only morally is it the right thing to do to get vaccines to those who need them most, it's the epidemiologic right thing to do. It's the economically right thing to do. And we can't seem to make that argument well enough around the world. So here's where we are. This is a few days old. More than 11.7 billion doses of vaccines have been administered to date. 41 million doses are administered on a daily basis, which is really quite incredible if you think about it. But only 59% of people have completed the primary series, vaccination series globally, and only 13% in low-income countries. So there really is still this grotesque division in terms of the haves and the have-nots. And it's about access, it's not about charity. So the COVAX facility, as you know, has worked really hard to make sure that those doses reach those who are most in need. And it's still working. You know, WHO and partners are still working to achieve that. We break this down by coverage by WHO region, and you can see quite some division, diversity, heterogeneity within region, with the lowest coverage in the African region. We also try to look at this, as you know, we have the 70% target, but it's not just 70% of the population, it's who within that 70%, 100% of healthcare workers, and 100% of those who have underlying conditions. And if we break this down by high-income, low-income countries, you can actually see how many people we are missing. So when we work with countries, we talk to countries, we say, not just who are you vaccinating, who are you missing, and what are you doing to actually reach those who are missed. Another way to look at it is the goals, the targets of 10% coverage, 40% coverage, 70% coverage. You don't need to see the actual numbers there to look at what's in red. Those are the countries, the number of countries that will not reach those, have not reached the targets yet, and will not reach the targets that the Director General set for the end of June 2022. So there's a lot more work to do. If we look at risk communication, we know community outbreaks begin and end in communities. We always know this, but risk communication, community engagement always seems to be something that is thought of a little bit late with not enough investment. This is changing. But there's a lot of work that we need to do with partners to really engage, inform, build trust so that communities actually have the knowledge and the tools to keep themselves and their loved ones safe. And then we have spent quite a lot of time of working on the clinical care pathway, making sure that we have integrated management for COVID-19 with respiratory diseases. And this is sort of how we're thinking going forward. Wherever the patient shows up, what tests do they need? What clinical care pathway do they need to get in? What access to therapeutics can they get as quickly as possible? And making sure that we have strong IPC and we have a strong health workforce. So our clinical care pathway is C for confirm, make sure that we have strong diagnostics and rapid return of results of those diagnostics, that a patient is assessed rapidly for symptoms, risk factors, and severity. We respond with the appropriate care and treatment, and we evaluate the clinical response all the way through recovery, and this includes post-COVID-19 condition. So we know we can significantly reduce morbidity and mortality with early clinical care, as well as by increasing vaccination coverage. And so this is a bit of a messy slide, but we're trying to look at how we use COVID-19 to have much more integration with respiratory disease management, everything from surveillance through diagnostic and care pathways, and of course with prevention. And we're trying to think of how we do this in every single country, increasing primary care, universal health coverage, and making sure that surveillance systems are linked to testing, are linked to action. So if we think of the future, I'm going to spend just a few minutes on the future and then I will end. Any analysis of this, suggests that this will continue, that this pandemic is here with us. Our ability to eliminate or eradicate this virus was lost very early on, even if that were even possible. But I, for one, think that this pandemic did not need to be as bad as it has been. And COVID-19 was disease X, but the next disease X is out there. So what do we need to do now with the trauma that all of us are facing to build a system for the future? So we have been thinking about the global health architecture and what this means in terms of how we think through what has been built over time, over decades, the current situation of the pandemic, the investments that have been made, and how we move forward into the future. So this pandemic has had a significant effect on all societies, on health, on the economy, on education, on climate, on poverty, and these are just some of the statistics. But I think we forget, I think we just gloss over these statistics because we've just become so numb to these. We're talking about trillions of dollars, billions of dollars, trillions of dollars. It's not tangible at the moment. But every single person in this room, every single person listening to this has been impacted by this virus. Every single person on the planet has been impacted by this virus, whether they've lost a loved one, whether they've lost a job, whether they've had their future significantly altered. And I think all of us have had our futures altered. And I think we need to use that to build something better, because it will not be the last. You all know this. You all work in this field. Savino and I were talking about this on the way. We love our jobs. We love the science and the field that we're in, because it's just so interesting and fascinating and devastating, to study these types of things, but it will not be the last. And over time, we have seen emerging disease and re-emerging diseases. So we need to be in a better situation. So in the context of this, our Director General has asked, how do we strengthen the global health architecture? How do we deal with this as we go forward? So we've been developing proposals around this, and we've been seeking some input on this. This will be discussed at the upcoming World Health Assembly this month, in a few weeks from now. And what we had a lot of reports. I think all of you, I don't know if you've gone through this, but we've also had the epidemic of reports that talk about how we need to do better. And this is good. We welcome this. As WHO, we welcome this. We also think many others need to do this as well, because there's always something to learn. But going forward, we need to address these systems, these major systems gap, and looking at governance, looking at systems, looking at financing, with underpinning of equity, inclusivity, and coherence. So the health emergency preparedness and response calls for intersectorial coordination. So of course, we've seen this with One Health and looking across many of the different aspects of agriculture, and agribusiness systems, economic and finance systems, social welfare systems, environmental systems, and health systems. But we need to make sure that we use this One Health approach. One Health is back in fashion. It never went out of fashion for those of us in this room, but there's much more interest in this now, and there's a lot of investment in this. So this is another opportunity. It's another catalytic moment for us to make the changes that we need moving forward. Because we know that no one is safe until everyone is safe, and this is certainly true in the global interconnected world that we live in. What we want to do is build systems that start at the most local level. We build the capacities, the detection, alert, and response systems at the most local level. We have the capacities at those local levels. So the systems are in place to prevent, mitigate something that happens locally in terms of a spillover event into something that could become bigger. And one of the things we talk about a lot, is that pandemic preparedness is not, it doesn't start and stop. There's no peacetime anymore. There never really was peacetime. We had these periods where things were a little bit calm, but those of us in this field have always been trying to push the envelope a little bit more. But we need to really understand these systems across all of the different pandemic cycles, these epidemic and pandemic cycles. We are living in a cycle of panic and neglect in the middle of the worst pandemic we've dealt with. And we get it, right? Nobody wants to talk about this anymore. Everybody wants to move on. But unfortunately, it's not over. So how do we use the time right now? I keep repeating myself. How do we use the situation and the trauma that we have right now to build that system going forward with the investment and the sustained investment going forward? And I'm really concerned, because now we're seeing these things being dismantled. We're going to have this happen again. So this is another view of the same thing around this global health architecture. We've got some 5 C's here of collaborative intelligence, community protection, clinical care, countermeasure access, and emergency coordination. But I have a 6th one, common sense. And I think a lot of that has been lacking in this pandemic. And a lot of it has been lacking in terms of our ability to use this. Maybe we can also add communication in here too. All has to be underpinned by strong, sustainable financing, governance, a very strong and respected workforce, and innovation. And I think I'll stop there. Thanks very much.
Okay. Thanks a lot, Maria. Very inspiring and more than that, more than inspiring, I think. But anyway, I didn't get any so far question from the internet. From the internet. This slowly. So I give the word to you.
Okay, well, first of all, thank you, Maria, for this fantastic lecture. I mean, and I think we should all thank you and, well, the World Health Organization. Anyway, I'll make my very quick question. So, from I could get from your talk that relate to this pandemic, there are two challenges now. The first one is how to vaccinate, especially those regions where we have under-vaccination, like Africa, and maybe even countries like even Brazil or United States, that to have still, although we have a good level of vaccination, there are certain regions that have less vaccination. So my first question is how to go a little bit further to make sure, because that's how the chance of a new variant, especially that worst situation, may appear. Related to that, I think the other point, and I'm feeling now here in Brazil, we are now using, and I'm sure other countries are using, we're using the what we call the home tests, and these tests, the system are blind about this test, because people get sick, get positive, and don't say anybody, because usually because they are vaccinated, then they wouldn't evolve with 5-10 days of disease and with mild symptoms. So how do you deal with that? Because that would be quite a lot, and that would give this false situation that you have a control. So in Brazil now, I think we have about average 20,000 cases per day, and maybe it's not 20,000, maybe it's 40 or 100. But well, and if you think that in other countries like Africa, that eventually these tests will become available at low cost, and how you think one should deal with just these two problems? The first one, that's the big one, that vaccination that has proved really that has reduced the number of deaths. How can we do that? Like countries like United States, even Brazil, that have a good amount of vaccines, that these vaccines can be sent to these countries that need these vaccines, especially because we are interested in that we don't get a bad variant. Thank you very much.
So thanks for the two questions. On the first one, with regards to increasing vaccination coverage, and there's a lot of different ways, and there's a lot of things that need to be addressed there. The first is we need more vaccine production, and so there's a lot of work underway to address that. But even among the vaccines that are available, it's about access. For countries' ability to purchase these vaccines, and countries across Africa have not asked for charity. They want the ability to purchase the vaccines themselves. They have control over when the vaccines will arrive, when they can distribute those. Of course, there's a lot of donations that have happened, and grateful for all of this, particularly through the COVAX facility, but also bilaterally. But there needs to be adequate time in which those vaccines are shipped, those vaccines are arrived, and the national vaccination plans can implement those. And that has not always been the case. So that needs to be addressed as well. Also, vaccination strategies need to be revised as coverage increases, focusing on who gets the vaccine first and how you prioritize those who are most at risk. There's also a lot of work underway on vaccine hesitancy in dealing with those who don't want the vaccine. And that can be said for low-income as well as high-income countries as well. And so there's a lot of disinformation out there. There's a lot of very strong anti-vax campaigns that are out there. And how do you reach those populations? You know, we were looking at some of the data. If you look at the recent example of Hong Kong and the high mortality that they saw, they had very low population level immunity because of the strategies that they pursued. But if you looked at the mortality was among people who were over the age of 70, over the age of 80. There were outbreaks that were happening in long-term living facilities. But if you dug a little deeper, why weren't those populations being vaccinated? Part of it, some people refused, but part of it is that they would show up to their healthcare facility and their doctors would say, no, no, you don't need it. You're shielding or you're staying away from others, so you don't need your vaccine. So it's how do you address that level of information and education and misinformation to target. So those are just 3 examples, but there's many ways in which it can be. But I think a lot of it is around equity. I mean, it's a fundamental factor of this which has not been addressed. And it's just where, look at antivirals, look at other therapeutics, look at diagnostics. We're not seeing equitable access. On the self-testing, certainly, I mean, the amount of self-testing has increased dramatically, and this is a good thing, but it's not linked to any surveillance systems. So we've been talking about this quite a lot, you know, of how we're going to have to figure this out. So actually, I look to you to help us figure this out, because self-testing is a way of the future. And you know, people want the access in their hands, but it has to be, we have to figure out a way to capture this into systems. Maybe not all of them. There was one test I took when I was in the States recently where you had to, a self-test was very expensive. I couldn't believe how expensive it was. That's another thing that needs to be addressed. But it linked to a QR code, and my result when I took it was automatically uploaded into some system. I don't actually think it was in the national surveillance system. I think it was in the company system. But the technology exists. We have to figure this out. And I think we need to do this soon, because self-testing, I think, is but it's not captured in, you know, in the trends that we're seeing here. And those samples are not sequenced. And so, you know, there's a lot of, we're blinded at the moment. And I have very little confidence that the decline that we're seeing in cases is actually that drastic. I mean, just look at the circulation right now of Omicron. So, but we have to figure this out. So I'm gonna probably be reaching out to your network, and we'll be forming some working groups. So just wait for that email. But we need help. We need to figure out how to do this.
May I?
Elena, please.
Thank you. Thank you very much for your fantastic talk. Just 2 brief questions. I was wondering, first of all, I want to thank WHO for the fantastic work you guys are doing. It's really incredible how fast and how quick you're responding, even though people, some governments, still try to give discredit. But my question is, very quick one, related to what's going on in China. Do we have any idea if it's a new variant, what's going on, why they closed down such big cities? And the other one, does the WHO has any idea of a time for vaccination for kids from 1 to 3 years of age? Thank you.
So they're 2 quick questions, but pretty tough ones, I think. I think, you know, what's happening in China right now, China's still following, they're calling it a dynamic COVID strategy. They don't call it a zero COVID, they call it dynamic COVID. They're dealing with Omicron right now, and they're dealing with BA.2, as far as I'm aware. I haven't looked at the data in the last week or so, but Omicron is incredibly transmissible. I mean, it really is, if you looked at how quickly it replaced Delta, it surprised, I think it surprised all of us how quick that happened. But they're dealing with BA.2, which is more transmissible than BA.1. And it's the strategy that they're following. So the cases that are reported, they separate out their symptomatic cases and their asymptomatic cases. And so what is reported on our tracking are the symptomatic cases, but they also have asymptomatic cases. And in terms of the policies that they're following, they're really sticking to this dynamic COVID, dynamic COVID strategy of trying to suppress transmission and minimize their impact. So that's what's happening there. But I do think, I mean, a lot of people come to us with questions, particularly about China, and particularly about transparency. But we really need to address this in all countries, because in this pandemic, we struggled as WHO, and thank you for your kind words of WHO, we struggled with many countries in getting information about many countries. And so this is something that's built on trust, it's built on reporting. A big issue we have right now are variants and the reporting of variants. We saw what happened with South Africa and them reporting Omicron, them reporting Beta, and how quickly the travel restrictions were put on. What incentive do countries have to report this information to us? We are only as strong as WHO as the information that we are providing. We do not have the mandate to go into any country, despite what people still think of us. I've been fortunate to go on many, many outbreak investigation missions for WHO, and each and every one, there's an element of a lack of transparency from governments. Every single one. And there's some countries I've never been allowed in to do outbreak investigations, and I won't go any further into that. But no, I'm not trying to make light of it. It's an issue. It's an issue for all countries. But I think with regards to trust, we have the international health regulations, which everyone talks about being strengthened, but that is an international law that all member states have agreed to. So we talk about this pandemic treaty, this pandemic accord that will be discussed. This is a contract. This is a promise of going forward. And I wish Mike Ryan were sitting here. He would have been a better guest, I think. He's a much better speaker than I am. But he talks about this as a promise and leaving a legacy that leaves behind for our kids and our kids' kids so that we're never in a situation like this again. So I, for one, believe in that. And I, for one, wholeheartedly believe in WHO. On the vaccination of kids, I don't have a short answer for this. It depends. It depends on the vaccines. It depends on the data that we have. Some countries are starting to do under 5s. I don't know when we will be making recommendations on that. It depends on the information that we have. We don't make flippant, as you know, but we don't make quick recommendations. We base it on evidence, which is why some people think we're really slow. But we have to do that because we have a global audience.
Sergio.
Maria, thank you so much for this wonderful lecture, but mostly I wish to congratulate you and your team at the WHO for the amazing response over these 2 years and your resilience in fighting all these difficulties and leading the way through this horrible pandemic that we've been going through. As a neuroscientist, I've been very much concerned about long COVID and the post-COVID symptoms that affect the neurological physiology, but also, as you mentioned, cardiac, respiratory, post-COVID remainders. And I wonder if I know you probably have your plate too full already with this more acute phase response with surveillance, care, and vaccination, but is the WHO thinking of considering some global coordination in terms of research and care for post-COVID syndromes?
Yeah, absolutely. So back in August of 2020, we had our first meeting on long COVID, which we organized with patient groups. We had these patient groups come to us and say, this is real, this is happening. We want recognition, we want rehab, we want research. And I went to our DG and I was telling him about this. I said, we're having this webinar, we're having this meeting. And he said, I want to be there. So he came and he said, we commit to this. And since then, we have a clinical case form, clinical case record form, so that data can be captured in a systematic way. We have a case definition now for post-COVID-19 condition. We are trying to coordinate cohort studies so that patients can be followed over time and that they don't just happen in high-income countries, but also happen in low-income countries in the north and the south and all over the world. But this is something that we are committed to that will require quite some effort. So it is in our, it's in my portfolio actually as the health operations lead under our clinical management pillar. We have people that are specifically dedicated to this and making sure that we are up on the research, we're following what's happening. We've incorporated some elements of post-COVID-19 condition care or clinical care into our clinical management guidance, but it's just the start.
Hi, thank you very much for the thoughtful presentation. My question addresses towards what usually has been thought as the paradox. Africa, in some areas in India, as Bihar. The cases in Africa, except of course South Africa, where there are more data available, but countries as Nigeria or Ghana or others that the population is very high, with low coverage of vaccination, we see apparently, at least what it is reported to WHO, low mortality. So is this a question of underreporting, or is there something else that is going on in terms of some sort of protection in those countries? The other thing is in a state in India as Bihar, in which you have a population of about 230 million people, in the size of a small state in Brazil, and apparently, except Delta that hit really badly most of India, we haven't seen other variants apparently circulating there. Thank you.
So thanks for the question. I think across Africa, which is a huge continent, as you know, the diversity in terms of the surveillance capacities, it's quite diverse. But if you look at seroprevalence studies, and there are a number of seroprevalence studies that have been published out of Africa, the seroprevalence is very high. And certainly now, from prior infection is very high. Some 60%, 70%, 80%, some even higher than that. So the virus has circulated in Africa. This misnomer that it hasn't circulated there, it's false. We don't have the same amount of testing that's happening. If you look at testing rates, it's a tiny fraction of what we've seen in high-income countries. So there's underreporting. But in terms of deaths, I think there's a number of factors that may be happening. Certainly there are missed, unrecognized deaths. And if you talk to colleagues, who live there, who have families there are many people who have died who have not been recorded as having COVID-19. And a death is very significant. You don't miss a death in the family. So there may be some factors that are happening in terms of infections resulting in severe disease and progressing to death. So the demographics are quite different. It's a much younger population. You have much lower rates of underlying conditions like cardiac conditions and respiratory conditions, et cetera. So you may have fewer instances of infections progressing to severe disease and dying. But I think there's a number of things that are happening there. I don't think Africa has been spared by any means. What the challenge is right now, and we're talking to our colleagues across the continent, is because it has taken so long for vaccines to reach, and now they're seeing, because you have such high level of population immunity, you may not see the same level of severity because people have some level of protection. It's not as severe as it was before. Why bother getting vaccinated? We do know that vaccination, even on top of infection, provides a strong immune response in terms of protecting against further infections and severe disease. But I don't know, we really struggle with the fairness of this. A lot of countries across Africa have gotten a lot of leftovers, have been thought of late. And we just need to change this. So it's a long-winded answer to say I think it's complex in terms of that. I certainly think there's a number of reasons why we've seen lower mortality, but I don't have it with me. I didn't look at the mortality estimates that we published today across Africa, but I know it's a fact. I don't even know what the factor is in terms of the unrecognized deaths.
There are 3 questions. Yes.
Maybe we have just 3 minutes.
3 minutes. 1 minute question and answer. Over there.
Thank you very much. Excellent. Very good. It's been said, and we all agree, that WHO has done an excellent job. But also, we hear that the budget is a big problem there. We talk about the future, more resources, more power. How is really the budget situation at WHO? Is getting the money and support that is needed for the president and going beyond that to the future? Thank you.
I could give a one-word answer, no. No, I mean, it's really, you know, that was my attempt at a succinct answer. No, we don't have anywhere near the budget that we need to carry out our mandate and to carry out the responsibilities that we have. We have a budget that's less than one hospital in New York. You know, and it blows my mind. I mean, we're talking trillions of dollars in impact we're talking about, and there's plenty of money out there, apparently, I hear. And there's lots of money being, you know, being given to many different organizations. We do need the finances to be able to carry this out, and we never work alone. We work with partners around the world. We're very grateful for the money that we receive, but we certainly need more, and it's not just more, it's what we can do with it. We need financing that we can choose how that money needs to be allocated and where that money needs to be allocated, as opposed to it being earmarked for specific projects or specific tasks. That's what I can give you, but we certainly are working on that, and we're working on a the financing of supporting this global health architecture going forward with WHO at the center.
The utopia could be that every money for health could converge into WHO, and WHO take the decisions. But it's utopia.
Yeah, well, being a coordinator, I should stop the session, but it's very difficult to stop that session in particular. So my question is, of course, we all did lots of things to try and help to stop the pandemic. But the real thing that really impacted was vaccines, right? I mean, of course, all the prevention and masks and educational work was absolutely important. But the game-changing, I think, factor was vaccine, and the speed that vaccine came over, it was fantastic. My worry is they are all, I mean, 5, 10 private companies doing this, right? And so the whole of global health is in the hands of 10 different people there, or taking decisions on how to invest. And so my question is does the WHO has a good kind of relation with all those companies? Of course, mRNA it's a window for the future for rapid responses to different diseases that may come, disease X. But they will need these companies to be, I mean, aligned and in some way, I mean, engaged.
Your question is, do we have a good relationship with these countries, and should we have more companies that we work with? Should we have more platforms? Should we have more production in different countries on different continents?
0.0001% of Pfizer's profit should go into WHO, for example.
I don't know if I should answer that question. It's an issue. I mean, I do think, again, this pandemic, I think, has changed everything in that sense. And I don't know, for me, we think about this a lot. I just think we have to think I don't want to see us go back. We can't go back. We just can't go back to the way things were. But how are we going to make those changes? This, you know, I don't know, the world is driven by money. And I think as scientists and as public health professionals, I think we need to do a better job of not only talking about how our work helps people and saves people's lives, but we have to address the economic impact of it. If we could do that better, perhaps we will be able to work with leaders more effectively. And I think, you know, this is something I've learned through this. You know, you can have the best science. We're all looking at the same data. But to have guidance turn into the right policy and be used at the right time with an engaged public that trusts you, you know, and modified as necessary based on the context, we all have to do a lot better at that. And I think communicating this type of thing across leaders and politicians, we have to make not only the public health argument, we have to make the economic argument and the livelihood argument much better than we currently do.
This leads to my question. To what extent either WHO conducted or coordinated a study, global, in terms of global studies, or even in some models, Brazil, for example, US, etc., to what extent fake news did have an impact on death by COVID-19?
I've seen some studies that have, I don't think we are, I don't know the answer to that. I'll check with my colleagues, but we have been looking at, what we are studying is this infodemic, and we have a lot of social listening platforms where we're tracking the different trends over time and the misinformation, the confusing question. I mean, certainly there's a lot of it's complex, right? So a lot of people have legitimate questions. We're tracking major sources of misinformation and disinformation, which we can address through addressing myths and myth busting. We're looking at social listening through different types of communities and religious leaders. We're looking at some of the statements that are made by different politicians. So we're tracking that. It's not necessarily a research study. We're also, there's some reports that have recently come out about looking at public trust. I mean, I could say without question that misinformation and disinformation has killed in this pandemic, without question. How we can quantify that, I'm not so sure. But the politicization of this virus and every aspect of this has floored me, I have to say. And so it's something that we need to really think through. There are sciences now around how we study this. So I think there's a lot of room. You know, maybe this will be part of the Brazilian Academy of Sciences and looking at the infodemic and how we study this. But I think it's something we need to take from this particular pandemic to quantify and actually look at how it can be addressed at the root core. But anyone can say anything these days. And there are so many different platforms out there where anyone can say anything, anyone with a mouthpiece. So this is why I think I've taken this responsibility of public speaking so seriously, the responsibility of this. A lot of people think that that's actually my job, is to do the press conferences. And it's for the record, is not, or the live Q&As, but the responsibility of that to say what we know and what we don't know, what we're doing to find out, I take huge weight. And we don't always get it right, and I don't always get it right, but we keep coming back, and we keep coming back to try to address it again. So we're, imperfect at best, but I think organizations like ours, organizations like yours, we were talking about this in the car on the way here. I think as scientists and with events like this, we need training in these areas. And I think as part of the curriculum, maybe through master's courses or something, we have to deal with how the work that we do is translated to the public, because the information is just out there. And people are craving this kind of information. People are smart, but it gets misused. So I've been burnt a few times on certain words, 1 word, 2 words, which I still can never say again. But we keep trying.
Okay, thank you. I pass the word to you, coordinator. Thank you.
Well, thank you again, Maria, for... I could think of a lecture that could represent the futures now. And so I would excuse, I will turn into Portuguese, but I think you have a... So, bem...
O equipamento de tradução. So we are going to continue with our theme session, that is life and health, as I just mentioned. I think now we had the pandemics, an excellent presentation by Dr. Maria von Kerkhove, and we want a future without pandemics, but with a better life. I think that the 3 presentations that are going to be addressed now will show us that we want to live longer, but also to live better with a better quality of life. I had a few comments here, so I'm going to summarize and call to the stage our main speakers. I'm going to call Professor Alicia Kowalstowski, Professor Michelle Satianaslavski, and Professor Sergio Ferreira, my colleague from the university. The first presentation will be by Professor Alicia Kowalstowski, and they have a huge bios, so I'm going to summarize. Alicia, I've known her for a long time. She graduated in medicine, and she is a professor of the Chemistry Institutes of the University of São Paulo. She has many titles and papers published, and she was a researcher at CNPq and a great researcher, and she's going to talk to us. It's better to listen from her, and she's going to defend her resume, and she's going to talk about calories, restitution, and aging, and mitochondrial connection, and that's it. So the floor is yours. Thank you very much, Gerson, and thank you, the Academy, for inviting me. It's a huge pleasure to be here in person, looking at the faces of some of you. I think this is a new hope to bring more science and to discuss more science this year in a growing manner. As many of you know, I have a lab that studies the energy metabolism and especially the mitochondrial one. The mitochondria is the center of most of the metabolic reactions that generate energy to our cells. The mitochondria are the batteries of our cells. And we get interested in understand the metabolic changes that contribute to the aging, especially how we can modify the metabolism in a way to age healthier and to age better without diseases related to age that generate undesirable aging. In this regard, let me see if this is working. I'm going to call your attention to another pandemic that lasts for decades. I want to be optimistic to believe that we are in a better phase of this viral pandemic, although we do have to take care and to be careful. And but for decades, we have an obesity pandemic. This obesity affects 500 million people, the same officially contaminated by coronavirus people. And every decade, we have more and more people developing obesity and overweight. In spite of educating the population about nutritional effects and the undesirable effects of obesity, obesity worsens our aging. It brings an increase of likelihood of many diseases related to aging. It increases the chances of dementia and cardiovascular diseases, the likelihoods of many cancers and diabetes type 2. So it brings a non-healthy aging. On the other hand, only educating population about that and bringing nutritional information has not worked isolatedly because we are metabolically programmed to like high-calorie food. For many, many years, it was an advantage to eat more and to deposit more fat because we lived shorter and we had few access to foods. In the last 120 years, the life expectancy is over 40 years old and we have more access to foods, and obesity become a public health problem because it brings along all the consequences of non-healthy aging. That's why my lab believes that besides educating the population about nutrition, we have to come up with molecular mechanisms, the molecules that are changed behind metabolic diseases associated with non-healthy aging. In this regard, that we work with.
And we work on that, especially studying animals in labs, especially mice, in obesity models, and in non-obese healthy mice. In that sense, we have an advantage that most lab mice are raised with ad libitum diets. So they get rations that they can feed on freely. And just like any human, they get chubby if they eat freely. And most of our mice are a good model for obesity. They're chubby. And several of the laboratorial alterations that you can see in humans, you can also see in mice, including in terms of type 2 diabetes development, which will be the focus of this study. However, if you restrict the diet of these animals, if they eat 30 to 40% less calories, they look a little bit more like healthy humans. So we make that comparison between these mice which were raised with ad libitum diets or restrictive diets. So the question I will bring to the seminar today is, what does that do with our pancreas and with our beta cells, the cells which secrete insulin in our pancreas? My lab has been studying the metabolic effects of calorie restriction in several organs, but I wanted to bring up this one today because it's one that we have very new data for, and I'm very excited. I'm bringing you data that nobody else has ever seen. You're being tested now. So anyway, we take mice and we place them in ad libitum diets, and you will see them marked as AL for them to develop obesity. Then we also take mice and we place them in calorie restricted diets through which they achieve a normal healthy weight. In this mice, it's very hard to study beta cells, the insulin secreting cells, despite the fact that we know that obese mice develop type 2 diabetes, which has several alterations, including reduced sensibility to insulin and a failure in pancreatic cells. However, to study beta cells in these animals is very hard because they're a very small percentage of the bodies of these mice. Their diet demands a lot of time and attention. But we have an advantage. We have a model to study calorie restriction in cultivated cells, in cultured cells rather. So we take these mice that underwent these diets, we take their blood, the serum from their blood, and we insert them in cultured islets. And we analyze these cells in terms of what takes place with them. So we analyze insulin secretion, their final role, as well as their mitochondrial physiology. Because the role of mitochondria determines how much insulin will be secreted. So a few years ago, Fernando Sequeira, a doctor student who is absolutely brilliant, made a very interesting discovery that only just 24 hours, in just 24 hours, in the obese mice, the CR serum increased the insulin release. The white bars are cells which were incubated in the presence of animal serums that fed ad libitum. The black ones were cells which were incubated present in serum of the blood of the animals that had calorie restriction. What you expect in normal insulin is little secretion with low levels of glucose and a lot of secretion with a high level of glucose. And we see that pattern in the cells that were incubated with the thin mice. We don't see that pattern in the ones incubated in the serum from obese animals. So just 24 hours being incubated in the obese serum changes those cells and they no longer function optimally. So we usually think about pancreas failure and insulin secretion failure as a chronic effect of several years of hypernutrition. And we see that no, there's something in the serum of the obese blood that in 24 hours ruins beta cells. I won't go into the detail of this work. It was published a while ago, and you can read it. But one important data is that the secretion of insulin in beta cells depends essentially on the role of mitochondria, because in the presence of high levels of glucose generates in the mitochondria more ATP, the cell's energy currency. It affects the membrane of the cells, which leads to more insulin secretion. So the role of mitochondria in beta cells is determinant for the secretion of insulin. And we saw that in the serum of obese animals, that affects characteristics of the beta cells mitochondria concerning their exchange of information. So mitochondria are organelles in cells, but they're not static. They exchange material with the cell all the time. Two mitochondria, they join and then they separate and they exchange molecules. And this molecule exchange, this mitochondrial dynamics, is very important to maintain their role. And we saw that the serum from obese animals affects that mitochondrial dynamic. Just to give an example, how do we see that? So here we have cells in which the mitochondria were labeled in red. Okay, so they express a protein that is green when we activate it with a light. So we fire a laser at the edge of the cell, on the left of the cell, and the proteins within mitochondria, they glow green. And then we're able to monitor what proteins these mitochondria are exchanging with other mitochondria through the dilution of the green light in cells. We can consistently see that the cells incubated in the serum from thin animals, they would exchange 3 times more proteins. So they had more exchange of mitochondrial protein and therefore better mitochondria. So this study determined that the serum from thin animals improves mitochondrial dynamics. They generate more ATP, and therefore, because of that high level of ATP, they have more insulin secretion connected to high levels of glucose in these pancreatic beta cells. So they function better. So we characterized everything that takes place within cells with the thin animal serum. But for many years, we didn't know what properties this serum had that would lead to these changes in the role of mitochondria. And now we believe we do. That is the development that I want to bring you. And this is the postdoc work by Ana Bonassi from my lab. It's still in writing and is not yet published, but I'm very excited about it. So the first thing was to reproduce our previous data, and luckily they are very well replicable. They started with mice with ad libitum diet, which is in red, and calorie restriction diet. If you look at the first panel, you can see that the ad libitum animals gain weight consistently, and they grow pretty obese with age. And the ones in calorie restriction, it's not a severe restriction. They don't lose weight, they just gain less weight throughout time, and therefore they're thinner. She took the serum from the bloods of these animals, and she treated beta cells with that serum and looked at the mitochondrial function of these cells to reach a measure of these cells' metabolism. I won't go into the technical detail, but basically The other graphs show quantifications concerning the mitochondrial metabolism through oxygen consumption. So mitochondria use oxygen to create an energy, basically. We basically burn our food through our mitochondria, and the higher the oxygen consumption, the better the mitochondria is operating. Consequently, we saw that the cells that were incubated with thin animal serum, they breathe better. They have a higher mitochondrial activity. They have a higher production of ATP in their mitochondria than the cells which were incubated in these serums from the obese animals. So that's mice. Now, does that follow through with human samples? Does the serum from obese people create the same effect? So we counted on the collaboration of Vilma Martins and Thiago Góes, who provided us with access to their biobank. Their biobank contains samples from healthy people of various ages and with a lot of metabolic information and even nutritional history. That was very important for us. And we chose healthy people with no comorbidities of a specific age range of the same metabolic characteristics except for body mass. So their only difference was obesity or non-obesity. And we looked at the plasma effect. We didn't have access to serum in this case, but it's very similar. The plasma of obese women, thin women, obese men, and thin men. And we did the same experiment. We looked at the mitochondrial metabolism in beta cells incubated with the plasma of these healthy donors. We consistently saw that to incubate these cells with the plasma of thin women leads these cells to function exactly like commercial plasma. So this is a serum that we use commercially to cultivate cells in labs. And the plasma of thin women functions exactly the same as this commercial serum rather. And if you look at the plasma of obese women or obese men, it is quite considerably worse for these cells. So to be a man, especially an obese man, worsens the functioning of beta cells in terms of in comparison to the control group. So we also know that that also takes place with humans. But why? What does the blood contain that leads to the worsening of cell function in animal and human cells? I will simplify this whole story quite a lot, but we had a hint from the literature of something that could be related to adiponectin, which is secreted by our adipose tissues. Our fat secretes this hormone, especially in higher quantities in thin people, and it is more present in women, which was also a hint for us. In addition, we had seen a few years ago that in other types of cells, in vascular cells, the adiponectin present in the serum of thin animals would lead to signaling that increased mitochondrial function. So all of these hints led us to that belief that this could be an important hormone for the alteration we were seeing in the beta cells. And truly, adiponectin is part of a set of several different hormones that have many different effects in terms of metabolism. We knew that its lack was associated to type 2 diabetes, but we had not looked into what it did in these cells that secrete insulin. So we decided to look into that. And we had a very interesting result, a very surprising one for me personally. We did a control experiment in which we simply added adiponectin into the cells without any addition, just to see if it had an inflammatory effect. And we did that in the absence of serum, and we got a result that was completely unexpected. Before that, however, we quantified adiponectin in our samples, and we had the expected quantity. If you look on the left-hand side, you can see that the mice in calorie restriction have more adiponectin than the obese ones who ate ad libitum. And on the right-hand side, you can see that thin women have more adiponectin than obese women. And thin men have more or less the same amount as obese women, and obese men have even less adiponectin. That matches the literature. So, we looked into what adiponectin causes in the beta cells. Yes, to be a man is less advantageous in this case. So, what is the role of adiponectin in beta cells? This was the most surprising result of all. So, in cultured cells, they require serum. They have several different hormones that makes those cells grow and function. Typically, we culture cells in serum like FBS, which comes from swines. And in cells cultivated in that serum breathes well. It has high metabolism. If you remove that serum, the cells simply do not develop any detectable mitochondrial function, and they perish. That can be seen in the literature. And if we add only adiponectin in the absence of any other serum in the quantities present in animals or in thin people, these cells start breathing again at the same levels as if they would in the presence of serum. So adiponectin by itself is a great inductor for mitochondrial function in beta cells. Beta cells cannot breathe without adiponectin, and just adiponectin is enough for the metabolism to function, which is a completely unexpected result for me.
Having said that, we decided to see if adiponectin was enough for the beta cell to secrete insulin as it should. And really we can see here that the cell in the presence of the bovine fetal serum or adiponectin have similar behavior, secreting more insulin with more presence of glucose. So these letters are the amount of glucose, and we see the increase of secretion of insulin with the high levels of glucose. So adiponectin is an extremely important regulator of the beta cells functions that is reduced in the serum of obese people. Maybe if we put adiponectin on top of this serum or plasma of obese people, we can recover the metabolic function of the cells. So this is what we researched, and we got the plasma of obese patients and we added adiponectin on top of it, and you can see in the green bars that we had a recovery of that consumption of oxygen. That is a measure of the metabolic activity of these cells. We had a hyper recovery. They are breathing more because we are adding adiponectin in the amount of the lean serum. So we were adding what was already in the plasma of those patients. So that tells us that there is nothing in the samples of the obese people that worsen these cells. There is only a lack of can recover this function adding adiponectin on top of it. And this is extremely beautiful because this tells us that maybe we can treat that, and this is great. So we saw an effect in the cell metabolism. Maybe there is an effect in the insulin secretion. So I'm going to separate the data here with women and men. We measured the secretion of women in 5, 18, and 16 millimolar of glucose in lean women, and it behaves as expected. In the plasma of obese women, unexpectedly, we had a high release of insulin that didn't respond to the levels of glucose. Maybe that was because the cell is dying and it's releasing insulin in the middle. So we were measuring the other panel in the right, that when the cell dies, it releases hydrogenases lactate. And in plasma of obese women, this is what's causing cell death of these beta cells. If we add adiponectin on the top of this plasma of obese women, we inhibit this cell death, and the cells start to behave in terms of insulin secretion exactly as they should, secreting more insulin with more glucose. In the case of men, the incubation with the plasma of lean men leads to a secretion of insulin as we expect in this letter. The incubation with serum of obese men does not lead to these letters, so they are not secreting insulin properly, but if we add adiponectin on the plasma of obese men, these cells return to secrete insulin as they should. So the plasma of obese men led to cell death lower than the women, but again, the adiponectin prevented the cell death. So the final conclusions is that we saw that either the serum of obese animals or the plasma of human obese subjects cause acute B cell dysfunction, and this is related to mitochondrial dynamics and the lack of ATP in the mitochondria because there is a change of molecules in this mitochondria. We found out that this is true because of a lack of a hormone, a specific hormone. This hormone is the adiponectin, and it is capable, adiponectin is capable alone to promote the beta cell respiration in the absence of any other component of the serum. We also managed to revert the bad effects of the serum just by adding adiponectin. And this is very interesting because it opens the possibility to prevent the degradation and the pancreas lesion and injury, which is one of the important factors of type 2 diabetes development. I need to acknowledge the people who actually make the experiments in the lab, especially Fernanda Cerqueira, who did the preprints, and Ana Bonassia, who is the lady in red in this picture. Ana Bonassia is not only an excellent scientist who found out this in the middle of the pandemic, it's a very difficult work to be done. She's also a scientific disclosure person, and she worked a lot to fight misinformation during the pandemic. She has a channel. If you have never seen a scientist, if you don't know, this is the name of the channel. It's very interesting, and I want to thank you for your attention. Thank you very much, Alicia. Now I want to pass to the next presentation, Michelle Satayanaslavsky, Professor of University of São Paulo of the Biomedical Science Institute, graduated by the Federal University of Pernambuco with a doctorate in University of São Paulo. He's going to tell us about the genomics and how elderly genomics improve precision medicine and the elucidation of factors associated with aging and longevity. Thank you very much for the invitation and for the opportunity to speak to you. I'm a little too tall here. I'm going to tell you a little bit of the projects of our group. I am a professor for 4 years of the genetics department, but for 12 years I work in the research centers of genomic and stem cells with Professor Nayama. First, I want to bring to you an overview of these promises of what we call the precision medicine, this new medicine that we stop looking at the disease and we start looking at the individual before being called a patient. So the idea of the precision medicine is to try to follow people's life in a way that we prevent and to predict a few risks and to prevent the diseases, to reduce the costs in public health in general. And these expectations are very high. Since the end of the human genome project, and with the technology of sequencing of the new generation, this is a very known curve in the areas of genomics. We had a sudden drop of the figures of the sequencing of genomes, including exceeding the Moore's law, which is a theoretical curve to improve the computational capacity and reduction of costs, reaching a level of $1,000. This is a situation of public health in Brazil is very high, but $1,000 is a reference value in the area of health, considering that a genome you won't make more than one time in your life. So this is the first part of the expectation, because what you can find in a genome can be taken to health, to what they call the bad science, to take to the patient that is searching some type of health. The diagnosis, maybe it will be the first beneficiary of this new technology, of this reduction. This is an example of rare diseases, monogenic diseases that affect families and somehow shaped the history of humankind. This is the case of hemophilia in European royal families. This was one of the greatest beneficiaries of this cost reduction. So about 1,500 monogenic diseases were already mapped that had their genes identified, that the genes that has alterations segregating in the families. And this, in fact, helps the families with the rare diseases to close the diagnosis and to help science find the mechanisms and to understand further the cases. For those who were curious, the coagulation 9 factor was the case of this factor in 2009 that they identified what was happening in these royal families in Europe. But the precision medicine also expects you to find new drug targeting. We saw interesting examples from malicious, and maybe who knows, we will understand why some people stop producing adiponectin and others don't, and this type of variation brought for the intervention. This is an example of this lipidemia. So there is one of these pointers. This PCSK9 causes degradation of LDL receptors. So in a population, African population, they found out that some people had mutations, that they lost the function of these genes, and these people had low levels of LDL and lower prevalence of cardiac diseases. And thanks to this recovery, the PCSK9 became a target of a $10 billion market to reduce the LDL in other places who were not fortunate enough to have this genetically. The reduction of pharmacogenomics, when we are finding or trying to take a medicine to find a response, a desired response to this medicine, some people do not present response, but some people present adverse effects. So we have people who are not benefited in the end of the day with all the drugs, and the pharmacogenomics has this promise. In some places in the world, this is already incorporated in the clinic. We know that in Brazil, this is not so easy. This interferes in the pharmacogenomics, and the main names in Professor Soares Couto here studies the pharmacogenomics of Brazilians, and this is a promise that has moved forward in the direction of precision medicine. And lastly, I talked about the rare diseases, but most of the people affected were affected by common diseases. And the prevalent diseases has a genetic component. The polygenic put them in a lower or higher risk. So instead of having one mutation that in your family that leads you to have a high risk of the disease, in fact, you have a normal distribution of many and many variants, common variants of low individual effects that combined, they put you at risk. Of course, in order to find out these combinations, we need a lot of samples and a lot of databases. And it would be very useful to find the people who have high risk in order to monitor their health and to make types of intervention, to make some follow-up, to make the system smarter. So facing the promises, we also have high complexity challenges. And this is a picture that was in the Human Genome Project, the first one that completed the comics. That was 8% that was published later. To put the puzzles does not mean only having the pieces. In the next century or in the next centuries, we have to interpret everything that we can see. So with this initiatives as the UK Biobank decided to collect systematically people from England to follow their trajectories of health, and from the moment that they published the genomic data of 500,000 individuals, there was a burst in applications, and with the polygenic risks, this is one of the most important papers where you can separate people in high elevated risks for coronary disease, for example. The group with the high percentile has 5 times more prevalence of coronary artery disease than the average of the population, which is excellent. This is the path that we need to travel in the precision medicine. Not all the diseases respond equally. The genetic architecture is very unique. The skin cancer, for example, 0.7 and 0.5 is just flipping a coin. So how does that work in non-European populations? Not well. So taking the same type of test to a non-European population, in the case of African population, in schizophrenia, type 2 diabetes, and 2 very complex diseases, you cannot see the same distribution. So these are not predictive tests, and that makes us think that we need UK Biobank in Brazil, a Brazil Biobank, or a BBB, or something like that. I think many people would like to participate or should participate in this. We just need incentives. The timing is more than necessary. The studies are biased to European individuals. Recently, the Japan Biobank and China Biobank, there are Asian patients and non-European who are not represented. And just to close the idea of the challenge and to see what we did, these clear examples, when you have a molecular diagnosis of a rare disease, we need to filter. All of us have genetic variants that seem pathogenic, but not everyone has a rare disease. So the population filtering is very important.
So we need a Brazilian bank, and one that is useful for that type of study specifically. The rationale of using the elderly comes into play here. They have consolidated phenotypes. They've gone through more severe genetic disease through their lifetime, and they consolidate the comorbidities throughout their lives, making them great individuals for that type of data bank. That's the rationale that Mariana raised in 2008 and 2010. We created this project of creating a data bank for the elderly. So we need a database of reference controls with ancestry matching for more accurate diagnosis. We need tools for interpreting that type of data. Because as they're elderly, we need to make sure that they didn't have, for example, muscle dystrophy. In the younger ones, we already have that uncertainty. And obviously study aging, which is a public health issue, which has been growing more and more severe in all economies. So we were very lucky to collaborate with the SABI study from the University of São Paulo, which since 2000 has been monitoring the elderly, collecting and monitoring data from these individuals every 5 years, funding allowing. We're still waiting for the 2022 approval. This was led by Maria do Celebron, a great epidemiologist who unfortunately passed away. And in 2010, we were able to collect samples, set up a DNA bank, and as you can see here, create complete genomes of almost 1,200 individuals from the sample. So this was a very extensive project. It was a collaboration with other countries, something which would cost almost $5 million. We were able to establish this partnership, and we have the data to show for it. We've also collected from cognitively healthy elderly, which are grouped separately. Brazilian elderly population gives us a lot of variability in terms of genetics. We have around 2 million variants, showing that Brazilians don't have so much participation in worldwide banks, and the populations which gave origins to Brazilians are as well. Brazilians are highly mixed, so every vertical line in this large panel, it represents one individual. That's a proportion of ancestrality. We have the Japanese population here represented. Most individuals, despite of their self-declaration, they are mixed. Most of these people have components from at least 2 or 3 populations in their genomes. That helps us understand variants in our patients, so it's a very relevant sample. However, they are still hard to interpret. This is another study. A data bank for clinical variants is still 3 times as likely for you to find any other type of information if it's in the European region of the genome. So there's a lot of obscurity in the international data banks to find what we're looking for. So we set up the Brazilian online archive of mutations, which has been active since 2016. People can access it for free. They can directly request aggregated files and search for several different types of variants. And they also have individual level data under request. So we can just add individual data online freely. Professor Maria Rita Passos Bueno coordinates the molecular diagnostics lab. This is Abraon, the database's web page. People's remaining time on the website is very good. The data we have from accesses indicates that. So that's very fortunate. This data bank allows us to input other samples. For those who work with genomes know that this is a serious issue. Imputation leads us to in-depth knowledge. We can sequence the SABI cohort D, and we are studying phenotype modifiers. There's a genome reference add-on for Brazilians. The polygenic risks are being studied in collaboration with the Einstein Big Data Group. We know that the Brazilian population is very different, and that gets in the way of importing polygenic risk scores. But there is hope. AOC has data that Brazilians are admixed, but there's a very high degree of European traces. This is a map of the genetic structure of Brazilians. Sometimes they seem more Brazilian depending on the region, or more European or more Asian depending on the region. Because there are no Native Americans in the data bank. The Asians are the ones that are closest to them. As a reminder of the spread of humans throughout history. So, we have the DNA from more than one point of time. This is a pilot project. Methylation changes a lot. Telomere shortening is also a factor. It's much more interesting to see it over time. You need to be able to see the curve for these people. Blood samples was also a factor. It was done in partnership with Vicese from Unicamp. We have interesting data about mitochondrial function in the elderly throughout time, as well as phenotyping over time. For example, what is declining, and what is being converted into disease, as well as what is not being converted into disease. So people who have severe mutations who did not develop breast cancer, for example. So we have projects to monitor all of these families now about what is protecting them. So the brain bank, we're also looking into the data from elderly people who passed away, and we see things like APOE. It is a very aggravating factor for Alzheimer, but it has weaker effects depending on the phenotype, demonstrating that the Brazilian population could contribute as known markers. This is a sample panel for COVID. We're also monitoring extreme COVID phenotypes. The elderly come into here as one of the samples. So elderly who are in the inflammation baseline, for example, they're always more susceptible to pass away due to COVID, and we research the opposite of that. Elderly people who were able to overcome the disease very easily. We also studied that. So to study large samples of Brazilian elderly people is very useful for various situations. So this is my takeaways. Brazil requires more large projects. We consider ours small. 1,200 is very small. We want projects with 50 up to 120,000 people. The future is now. So we need to set these systematic biobanks now. And we know it's hard to get good quality data, but we know that a few OPSs and some family health centers have their electronic equipment for that. This is something that Brazil could contribute to the world, to study the mechanisms of diseases and help our own population to make use of precision medicine. Otherwise, it's just another wasted opportunity of growing asymmetries in health. That was my message. This is the Abraham group for the last study and ongoing collaborations who are working with me in these projects. My email, my lab is LAMP4, Preventive Personalized Participative Medicine, which is the fancy name of precision medicine. Thank you. Thank you, Michelle. An excellent speech. Just a comment. 2 weeks ago, there was a FAPESH proposing partnerships, not just between Rio and São Paulo, but also in spaces like precision medicine. So I had not yet seen your talk. Now I am convinced. So now Sérgio Ferreira, he has a vast curriculum. We are laboratory colleagues. We are advised by Sérgio Veskovsky, who then moved to USP. He's a member of the Academy just like Alicia, and Michelle soon will be. A distinguished researcher. He would talk about the challenges and opportunities
of research in dementia? My genes have not given me height, so it's a great pleasure to be here once again. I'd like to begin by thanking Gerson for the organization of this amazing session, for the conference itself. When I was invited, I was sort of surprised. I thought it would be online, so it's a very pleasant surprise to be able to be here in person. Hopefully, in the next few years, we can have this room full as it has always been the case. When I got the invitation, knowing that the theme of the conference was "The Future is Now," that brought me back, because since my high school days, despite the fact that I pursued natural sciences, I've always enjoyed history. And I'm very much convinced that in order to understand the present and predict the future a little bit, we have to know about the past. Also in the context that we've been here for 4 months since in which we will commemorate the independence of Brazil, I decided to look at the data about life expectancy in 1822, when Dom Pedro was riding his horse across Brazil. The yellow color indicates that in those countries, the life expectancy was lower than 54 years. Making a giant leap to today, this is the current map. The stronger colors indicate a life expectancy that is a lot longer, not just in developed countries that are dark blue, life expectancy of over 90. Here in Chile, in Latin America, we have Chile. Life expectancy in Chile has overcome 90 years old. But in other countries that are more developing, we have life expectancies of over 70, 75. Certainly, this increase in life expectancy was a result of the progress of medicine throughout the years, which then reflect the progress of research in biomedicine and in the medical field in general. So if you want a very simple demonstration of the importance of research in human history, this world map is a very good piece of evidence. So we live in an aging world. We have these two maps from 2015 and 2050, which is right around the corner, concerning the distribution of the elderly population, so those over 65. In 2050, even in the late development countries, we will have 25% of the population over 65. In the case of Brazil, this is the pyramid that Michel had in one of his graphs, one of his slides rather, the traditional wide base pyramid with a very thin top that is changed, and our forecast is for us to have this thick midsection graph. Around 25% of our population will be over 60. And that's great. However, what I want to talk about is that this aging of the population leads to an inevitable prevalence of chronic degenerative diseases. Among those, there is dementia. This is the graph produced by the WHO, published this year, showing the prevalence of dementia in the function of age. So in those over 65, the incidence, the prevalence of Alzheimer's disease increases exponentially. So over 90, around
40% of individuals will have Alzheimer's, which is the main sort of dementia or some other sort of dementia.
And that creates an important issue of public health in our country. And to give you a few figures, today we estimate that we have 50 million people currently live with dementia worldwide, and this number will triple by 2050. And a number that I think it is concerning that is the impact of this increasing of the dementia cases not only in the individuals and their families, but in the whole public health system in the countries. So we see that this data that nowadays the annual cost of dementia is over $1 trillion, and this number will double by 2030. It's not 2050. In 8 years from now. So it's just around the corner. So by 2030, we'll reach $1 trillion. And just as a comparison, I mentioned here that this is the Brazilian GDP of last year, 2021, 1.6 trillion. That was what the whole Brazilian economy, which is the 12th largest economy in the world, was able to produce last year. So in comparisons, in 8 years, the annual cost of dementia treatment will be more than the Brazilian GDP. Brazil can get all the money and lend to WHO to treat these patients, and it won't be enough. It is a serious problem, and if we stay here, of course we have emerging and urgent problems with infectious diseases and COVID more recently, but not only that, dengue, chikungunya, and Zika virus, and malaria, and Chagas disease, and others, we have to worry emergently with those. But if we are lying here expecting what will happen in the future, I think that the risk is that we are going to see ourselves surprised not only without warning, but surprised by a tsunami of cases of dementia in the country. And I think that the public health system in Brazil will not handle that, as it will not handle the public health system of many countries who do not prepare for the arrival of this increase of dementia cases. So in order for us to have a less catastrophic situation that this slide aims to show, it is past the moment that Brazil has developed a national plan of Alzheimer or dementia, as many other countries already did. We are already late on that. Even in Latin America, Chile and Argentina already developed efforts in this regard, and Brazil is still crawling. And I think it is about time that we started doing that. Of course, that facing that wave, it is not only a wave of dementia, we have a wave of obesity, diabetes, and other diseases, and other cardiovascular diseases. And facing that wave, we think that we have to do something, research to heal this somehow. But the biggest problem in Alzheimer's and dementia is that we don't know the targets. So the arrows are being made at random with blinded eyes, so trying to reach something. So this is data from research 6 years ago, but the numbers didn't change so much in proportion. At that time, we had concluded 1,600 clinical trials in Alzheimer's since 2002, with a test of 250 different compounds, 250 potential drugs being tested. And despite all these efforts, not even one new drug is in the shelf, since the first one, because it is a very modest medication that doesn't solve the life of the system or the patients or the health system or their families. So one of the efforts that is being made is the premature diagnosis, because Alzheimer's, and that explains the failure of most of the clinical trials, that Alzheimer is a late presentation disease. When the patient develops symptoms and goes to the office and joins a clinical trial, the problem already started 20 or 30 years before. So the initial markers, for example, the changes in synapses and the accumulation of beta amyloids that I'm going to mention very briefly. So since the initial time of Alois Alzheimer in 1906, with the first patients that he described, we know that the brain of the patient, the Alzheimer patients, accumulates these lesions in the parenchyma, these deposits that we know that are constituted specifically by the beta-amyloid peptide and other biomolecules. And these are called amyloid plates. And looking at that in the brain of a dementia patient, it was very clear and intuitive that the target was this accumulation, these plaques. However, the studies accumulated throughout the last 12 years and 20 years, we have clear evidence about this, that the plaques possibly are not the most important species in the most toxic pathologies. They might have a protective instinct and protective factor because they protect the other balls here that we call the oligomers, who is also come from the amyloid peptides that are being dissolved in the brain, and the image in the right is substituted to the cartoon. This is a cartoon on the NIH that is substituted by an image made in our lab many years ago about an immunofluorescence showing the hippocampus, a region of the central brain for the memory, and these dots that I hope you can see, I don't know if you can see because it's very clear, these dots are sites of interaction and oligomers binds. So these neurons is filled with oligomers and it is dysfunctional. So this has motivated that even in the plaques or in the form of oligomers, he has motivated a huge intensity of studies aiming at fighting these oligomers and these beta-amyloid peptides in the brain. It's one of the strategies is immunotherapy, and we know a lot of clinical trials, maybe you heard of some of them, with specific antibodies that are generated against these peptides, so you can vaccinate passively the patient to transfer antibodies that blocks the peptides. And recently, one of the most recent is the aducanumab that you might have heard of, that was approved by FDA in the end of last year, not without controversies. The only 2 clinical trials with these antibodies were not successful, and then Biogen managed to make a mathematic in the postdoc analysis of the clinical trials, and they concluded that for some patients things worked, and FDA gathered a group of 10 or 11 panelists to approve or not the aducanumab, and the panel recommended the otherwise, and surprisingly FDA approved the use of the antibody. And it has been used initially with not a lot of successful results, and this failure is because aducanumab, besides binding to the oligomers that are the most important species, it also tackles the plaques and the beta plaques. So maybe part of this antibody is being lost, attacking the wrong target, and there is only a few left attacking to what it should attack. And not by coincidence, because this has been questioned in the literature. This is a paper that was published not less than 1 year ago, 1 month ago, a group of researchers proposing that aducanumab can be withdrawn from the medical treatment. So we had our 2 cents of contribution to these areas, and one of the things that we are doing is an approach that attacks the beta oligomers, but we believe it's more selective. So a few years ago, we collaborated with William Klein group in the University of Northwestern in Chicago, and along with us, he developed an antibody that is the NUSC1 that was developed by Adriano Cebolela, who was a student of the lab, and today he's the professor of the medical school of Ribeirão Preto, and he had the postdoc in this lab. And we characterize this antibody called NUSC1, and this antibody is very specific for oligomers, and he binds very specifically, and you cannot see the aggregated amyloids present in the plaques. And what we did in the recent study that was made by Clara Sejesk, who is an Argentine student that was in my group, Clara inserted this sequence, and we packed in a viral sector for this expression. So when we infected the neurons in culture with this virus construction that took the plasmidium so the new neuron could produce its own NUSC1, the neurons that are exposed to the oligomers has a huge bindings of the NUSC1 and suffers regeneration, and those who are expressing NUSC1 on the over direction of the viral sector was protected. And the most interesting is when we did a transgenic model with an APPS1 mice, when we used the memory test, the object recognition test, the memory deficits that these animals presented as they age, they are reverted after the treatment with this viral factor. So the expression of the antibody in the animals' brains revert the cognitive damage of these animals. So this is something we are interested in to eventually move forward with a potential perspective of genic and immunogenic therapy. But the issue of Alzheimer is not only the molecular targets. The other important issues are the cells involved. And up to some years ago, it was a neurocentric approach. We were basically worried about the neurons. But most of the researchers in the areas forgot that in the brain, there are other types of cells, as the glia cells and the astrocytes and the microglia, that are essential in the inflammatory response in the brain. So these cells have gained more importance over the years, and we believe that they have an important role in the protection and the pathogenesis of the Alzheimer's disease. I won't be able to get into details today, but if there is anyone interested, we can discuss about that. And finally, the other issue that has to do with the choice of the targets in the identification of them is that Alzheimer's disease, the sporadic Alzheimer's, not the ones that are family, that starts prematurely, the sporadic Alzheimer's diseases, they seem to be a complex combination of biologic, lifestyle, and social factors that we are interested in now. I borrowed this slide from Fernanda de Felice, and Fernanda has been interested before this area, especially in the issue that we call allostatic load. This is a terminology that I don't know if you are familiar with. This was developed by Bruce McKillen, a neuroscientist, well-known neuroscientist from Rockefeller Institute, and he died in the beginning of the COVID pandemic. But he had a sociologist brother who was working with the social factors in psychiatric diseases. And he was related to depression and depressive disorders and behavioral changes. And Fernanda inspired by Bruce McKillen, and she believes that we could apply these factors of allostatic loads that derives from the inability to cope with these daily social and environmental adversities across the lifespan. These can be biological, lifestyle, and social factors. And in this review that we've recently published, we introduced the idea of looking at allostatic loads in Alzheimer's disease. This is a pioneer notion that will leave the biological determinisms to look at molecules and genes and other ways, and to include social factors, lifestyle factors, and health outcomes, general health outcomes that converge or lead progressively throughout aging to the cognitive deficit and finally to dementia. So this is an area that we have an opportunity to open for new studies. We move away from the biologic perspective to move to the social factors. And not by coincidence, I am working with other colleagues in a special edition of this Journal of Alzheimer's and Dementia for modifiable risk factors in dementia, to look at the impact of these modifiable risk factors, whether they are sleep, in diabetes and obesity, sedentarism, and smoking or alcohol, or other social factors, and in what way these modifiable risk factor, potentially modifiable risk factors can be a way to prevent the disease.
In my last few minutes, I will talk about a few areas that we've been working on for several years, which is the connection between type 2 diabetes and Alzheimer's disease. This is a line of study that began in this first study published in 2009 when Fernanda was conducting her postdoc in BioCline, and we collaborated in this work showing that neurons exposed to oligomers exhibit resistance to insulin. And insulin signaling, which is very important for the functioning of the brain, drops. It's inhibited. And not because you lack insulin, but because the cell response to insulin is harmed. And after a series of studies led by Fernanda, she has been demonstrating several mechanisms through which the resistance to insulin is developed. This is partly due to what is being shown on the right-hand side here, to what we believe is a conversation between the remainder of the body and the brain. How the brain impacts what happens in the periphery, and how the periphery impacts the brain. And we saw that factors like aging, obesity that Alicia addressed, or even peripheral infections like COVID. We see neurological conditions deriving from COVID. So these acute infectious conditions could lead to a cytokine storm, which affects the brain and cause inflammation and so on, which leads to insulin resistance. In this slide, which I will not detail too much, it summarizes what we know today about how these signaling pathways for insulin and neuroinflammation intersect in the brain during Alzheimer and lead to memory loss. In the left-hand side, we have a pro-inflammation cytokine connecting to its receptor. On the right side, another cytokine, which is IL-6, connecting to its receptor. And in the center, the insulin receptor, which has its activity blocked by several different converging mechanisms, which leads to the inflammation condition, which leads to loss in synapses and memory loss, ultimately. So if I were to ask you, what could be good for a diabetic patient or obese patient aside from medicines, from drugs? Well, food and exercise, as we've been saying, and we've been studying exercise in depth. And there are several studies, epidemiological studies, and populational studies that show a connection between physical exercise and brain benefits, which include dementia prevention. The issue is how. How does that take place? There are many possible molecules that have been identified as possible mediators for that benefit. So what does exercise do that protects the brain? There are several candidates. And a few years ago, we started studying this hormone called irisin, which was initially described, not coincidentally, by Bruce Spiegelman, one of our popes of diabetics research. He identified that irisin derives from a precursor in the plasmatic membrane, not just muscles, but in other types of cells, many cells. And under exercise, this is cleaved and releases irisin, which is the goddess of messaging in Greek mythology. And that message, which he studied, was from the muscles to fat tissues, and it would cause browning. Creating the browning healthy effect. So in our group, we decided to investigate whether irisin had an important role in Alzheimer's disease. This was led by Michel Lorenzo, who is here watching us. So Michel Lorenzo, at the time, he was still a student. Now is our colleague. We have the privilege of having in our group in the Federal University of Rio, and Ondimar Froza from Fiocruz, and Guilherme, our doctors student in Queen's University in Canada. They initially demonstrated that irisin is decreased in the brain postmortem, as well as in the brain liquid of Alzheimer patients. So those who have Alzheimer's lack irisin. So we started studying the animal models. And in them, in their brains, in the oligomer injection, as well as in other studies, we saw that they lacked irisin as well. We collaborated with the IDOR group, and we obtained samples from a memory clinic, and we were able to dose the amount of irisin in the liquid of these patients, and we saw a correlation between their score and their amount of irisin. We saw that the more irisin you see in patients' brain liquid, the better the cognition, and vice versa. So there is an association. So we went to investigate if we could see that direct correlation in mice, in mechanisms that improve memory and irisin. And so we used 4 different approaches. The first one was the injection of irisin directly into the brain. The second one was to inject a viral vector which makes the brain produce its own irisin. The third one was exercise-based, so alteration of lifestyle. And lastly, a peripheral injection. The same vector we injected into the brain, we injected it peripherally. And what we saw was very interesting. The irisin levels increased in all 4, and as well as memory and synapses would also improve. So to increase irisin in the brain through any of these means improved memory. And the experiment which I believe was the most instigating was the memory test, in which they measured the memory-related behavior of the transgenic model using object recognition. So these are normal animals here on the first one, and we saw that type of behavior. They spend more time exploring objects that they don't know. They are more interested by a new object. The APPPS1 mice, they cannot discriminate a new object from an old one. They don't remember that they've already seen it before. So that's a pattern that we see in Alzheimer's disease. When we took an animal, a wild type, and injected them an antibody that blocks irisin in their belly, we saw that to block peripheral irisin affects their memory. So this conversation between the periphery and the brain is important for the memory of the animal. When the animals were subjected to swimming, so they swam for 5 weeks every day for 1 hour, we saw that even in the transgenic animals who already had a memory deficit, they start performing better in the test. So if you took an animal that had a memory issue, if you put them to swim, that would lead to an improvement in their memory. And then after the injection of the irisin blocking agent, that would return them to worsening results. So that correlation was made very clear. In conclusion, activity activates muscles, which activates irisin, which moves into the brain. So we've only partially elucidated the role of exercise in Alzheimer's disease. So I'd just like to leave you on a happy note. This was published yesterday by Jeffrey Cummings in Alzheimer's Dementia Journal, in which we see the current pipeline of clinical tests in phase 1, 2, and 3 for Alzheimer's disease. So we have tens of drugs which are in development. So I believe we have reason to believe that one, if not a few, will work. And while that goal is not reached pharmaceutically, we need a combination of healthy eating with exercise that's now associated with irisin. Maybe maintaining a regular exercise program, we're able to keep Alzheimer's disease at bay. Just to close now, Gerson will kick me out very soon. If we remember that first panel of the allostatic load, maybe through an intervention program that could include lifestyle as well as social interventions. So that's key, to reduce inequality, take care of stress, and ways of manners, all manners of violence throughout the entire lifespan that could increase the period of our healthy life. These were the most important slides. This is the most important slide, rather. The contributors. First of all, Fernanda. Since we started studying Alzheimer, we've worked together. Michelle, our colleague who's here today that I mentioned, Jorge Marcondes, and Sonisa for the access to the human material in the University Hospital of Fundão. Rudimar, the DOOR team in São Paulo, Adriano, and the international collaborators who have made this project possible. This is just for the work that I showed. We're extremely lucky to be able to count on a vast network of international collaborators. And finally, the current members of the lab, our postdoc students, and our technical assistants. Forgive me for going over time. Yeah, there's still time to produce irisin. So now we are still on time. Let's start with the questions that came from YouTube. Professor Lisiane Porciuncula. It's a question for Alicia. Was the dosage of sexual hormones made in the samples in your study? And what would be the impact of those hormones? If there was, basically the question is, was there a difference between men and women?
No, we didn't dose, but there are differences between men and women. The age group that we analyzed was young at the middle age. It wasn't expected for the women to reach the effect of menopause. We wanted to avoid that. So it was expected the normal levels of hormones, both for men and for women. So, but it would be interesting to see, since there are differences. Yes, it is interesting because women tend to be more obese. We have more type 2 diabetes in women because of more obesity and more dementia. On the other hand, men tend to be diagnosed with type 2 diabetes earlier, more frequently, and in the absence of obesity more frequently. Maybe this is because of these low levels of adiponectin that men have. So just making assumptions here. There is one more question from the internet to Sergio. So how to mobilize in the government bodies and to wake up and act on the prevention and finding drugs for neurodegenerative diseases? Well, this is a question that is difficult to answer because there is no question that the first thing that the Ministry of Health needs to gain an injection of direction so it can embrace what science has been teaching us. In the beginning of the pandemic, we saw that an attempt, and then that got lost, unfortunately. But as the governments perceive that the map that I showed in the beginning, the increase of longevity and improvements of quality of life in its development and research, maybe we can convince the governments that it's worthwhile to invest in science, in the health area. Of course, many other challenges. The idea is how to use more intelligently the resource. It's not an easy question. I cannot answer that just like that, but I think depends on the determination on the state. It has to be a state policy to fight the chronic diseases because they will reach with the strength of waves in the next years. I wanted to congratulate all three speakers. They were great, and I am here a dozen questions, but I'm going to stick to only a few of them. First, I would like to ask Alicia if the reduction that you see of the leptin, if leptin has an important effect in the pancreas cells, both for the release of insulin and also with the cell death. As far as I remember, this was more associated with POF when you were considering LDH that suggests a death via pyroptosis, and it has a huge link with inflammation and chronic inflammation in these aspects. This is one leg of the question, but molecularly, adiponectin would act to regulate these effects. And you show that it's reducing the death effects. There are some initial studies showing that adiponectin can regulate inflammations, and there is a huge crosstalk with mitochondria and the mitochondrial dysfunction. And the chronic way, you've shown an acute effect, but how chronically this would be maintained. I don't know if Gerson, if I can ask the questions to Sergio. Well, Patricia, we need to talk because you know that inflammation is not my expertise and I have a lot to learn from you. But as you saw, we have this increase of release of LDH and a release of insulin with the women plasma, and it has an inflammatory effect because we do not see that in the men plasma, but it has an inflammatory effect that adiponectin is reverting. So there is a history behind that beyond this metabolic effect that we are seeing of secretion of more insulin. We don't have differences in levels in leptin in the plasma of the mice because they are fasted overnight. They spend the whole night without eating before recollecting. But in the patients, I would expect an increase in the level of peptins because it is highly associated with the mass of the adipose tissue. Well, the leptin would be typically changed in the obese people and to the response to the leptin receptors. But in the animals, the levels were not so different. It doesn't seem to us it is an effect of leptin. We went through many different hormones. We have a robust result of adiponectin in this study. Now, Sergio, I wanted to go back to the issue when you asked Maria about the relationship between COVID and cognitive deficit that we see that is associated post-COVID. Your presentation was very interesting, and I saw your research in it. There are interesting data. And I wanted to link with COVID. One of the main aspects that you see in the long COVID is the reduction of muscle forces, muscle strength. That is an aspect in the elderly patients that went through intensive therapy that has a loss of quality of life because of the reduction of muscular strength. Did you look at irisin in this regard to see how much this muscular strength can be resulted from the virus, if that would be reduced, and somehow contribute to this acute effect or this transitory effect that we see in the memory in this post-COVID and long COVID. This is a very intriguing question because in the beginning of 2020, as soon as the pandemic started, we published an article of perspective that was in the Transit Neuroscience that we was raising this flag here. Let's wait because there will be an epidemic of neurological case post-COVID. Unfortunately, the predictions came through. And last year we had a study using the UK Biobank, using data from the UK Biobank that Michelle mentioned, where we showed that patients with dementia, I'm going backwards in your question, but people with dementia and Alzheimer's diseases and other types of dementia, they had not only an increased risk of infection that was trivial and expected because many of them can have contact with caretakers and they live in institutions, but that was expected. But once normalized by that everyone that was infected, if you have patients with dementia or non-dementia with infection, the risk of aggravation and death are 6 times higher in dementia patients. So controlled by age and other comorbidities. So there is a clear correlation, and one of the things that we can imagine is that the outcome of COVID in these patients is harmed because previously they have low irisin levels. We didn't examine, now answering directly. The answer is no, we didn't, but I think it would be interesting. I think that the problem is that the plasmatic irisin is not a good level or not a good rate. If we have the blood of the patients, I don't think we will see any alteration. But how much irisin is in the nervous systems, and that's why we need liquor of the patients. But once we have access to the liquor of the long COVID patients, this would be an interesting target to research. I think it is a good suggestion. If you have a chance to have access to that, I think it would be great. Because in Alzheimer, for example, plasma doesn't vary between the plasma and control, the plasmatic irisin, if you compare the Alzheimer and controls. We only change the irisin that is in the liquor. So this is more related to the neurological damage. So we have access to a few cases of patient liquors of COVID patients. I want to thank for the presentations. It was very good. I'm a physical educator, and I'm very happy to see how much physical activity can change people's lives. I think that for the future is now we have to think about strategies to put people doing physical activity since early childhood, since elderly age. So I want to thank you to the value that you give to physical activity to the brain and human being. And our chair knows about that. He exercises very well. He started to squatting here. Thank you. Well, I really like physical activity, but drugs can also help. So the question to both of you and for the three of you, can't we take adiponectin or inject irisin in our genetic elderly populations with the genomic data of our healthy or elderly populations? Don't we have signals of those indicators? I would like to ask something actually. You said that adiponectin, released adiponectin, is associated with better mitochondrial results in the beta cells. And the cell that released irisins reaching the liquor is associated with better responses. Is that the same for everyone, or there is a variation in the population? What do you know about that? Because in practice, we have a phenotype, a natural phenotype that can vary from individuals to individuals, and that would indicate genetic factors that would give us our perspective to assess the risk at first and how the effective targets that are intrinsic to increase these apparently important messengers to our health. So I'm going to channel Glaucius' questions to you. Okay, so maybe I can start by answering that there is a huge variation in the population. Of course, they are humans. They are very different from lab animals that we control their whole life. You can notice that in our data, we have a number of samples to look at the differences in the population. And this is the importance of the biobank, because we had access to the number of samples enough to do that. So it is absolutely essential. As for the treatment for with adiponectin, as excited as I am with these results, the adiponectin is a different hormone than insulin that we inject in people. Although people produce naturally and they use for treatment for pathological situations. The difference is that the concentration of adiponectin in the blood is very high. It is a very atypical hormone in this regard. So we cannot inject subcutaneously to have enough amounts in the lean versus obese patients. It has to be endovenous or continuous. It's not something easy to be done. But whenever you identify a way, we know the receptors of adiponectin. We can think about drugs that activate these vias in these ways. We know the signalization below these indicators from literature data and from the previous paper. Now we have more targets, but adiponectin itself is 1% of the protein of the blood. So it is something that is very difficult to be used as a treatment of a chronic disease. And what if we use this cell therapy of a brown tissue of adiponectin as the one that was used? Good. This is another story. If you put up a system of generating the protein inside the person, we know only a little about what regulates the secretion. It is regulated especially to leave from the central adipose tissues. The less adipose tissues, more secreted it will be. So the mechanism to regulate that, we need to learn how to do that. Well, Glaucius, I see a lot of value in this idea of replacement therapy. This is a well-validated therapy in diabetes. For decades, people take insulin. Some patients respond well and others not so much. So I think that what we have to think about is that the issue of the secretion of insulin by the pancreas is half of the story.
The other part of the issue is insulin resistance in peripheral muscles. So fatty tissues, the brain. The issue is not a lack of insulin. Even if you add a charge of insulin, the neurons don't respond appropriately. So in the future, we may have hormone replacement for it. This may be an object of study in the future for sure. It's something we do for other types of hormones, especially in diabetes. So I see value in that. But as Alzheimer's is a polygenic disease, as Michel mentioned, there are a few genes which are 100% penetrating. So the familial cases that affect people at 45 years old. So then you have that mutation 100%, you will have the disease. However, others have 8% more risk, 12%, 30%, so it's polygenic. It's hard for you to have a single pill for it, you know? Even if our pharmaceuticals are developed in that sense, I see that lifestyle changes, and by lifestyle changes I mean social aspects of life as well, not just biological lifestyle. I think those will be the most important tool to prolong healthy aging and keep Alzheimer's disease at bay. I'm an eye doctor. It seems that this was made for me, so Alzheimer's, retins, OCT, mitochondria, glaucoma. So, Michelle, I loved your presentation. So, can you see any epigenetic characteristics in the biobank? We have data from very elderly patients in terms of visual capabilities, especially in twins. Do you have any data from Brazil about elderly twins or not, or in their gene characteristics to set aside genes from them? Okay, so I'm not particularly aware of elderly twin studies. We can't even find them, right? Yeah. Twins are a very good model for genetic studies. We're studying elderly people in their 80s and 90s who had COVID, who were resilient and overcame it very easily. The strategy of extreme phenotypes in that sense. And also those who live in the same house, one was negative, one was positive. So for your question specifically about elderly twins, no, but international studies have shown that yes, the probability of you being in your hundreds and have a brother also in their hundreds within an odd ratio of 5 above, there are genetic components for longevity. And the correlation is quite high. So genetics is aiding in longevity. Yes, it's not just about not having diseases. There are some genetic aspects that could help you. About your first question, we've had a first pilot study on that subject, my first partnership with the University of Toronto, with a 10-year difference cohort. In 2020, we were able to acquire funding for monitoring COVID patients and obtain DNA from individuals to make epigenetic studies. We know that there are a few genetic clocks which are correlated with chronological aging, but the epigenetic clock for sure is connected. We want to validate that to the Brazilian population. And I'm very interested in studying specificities in populations, whether that is the same for our non-European population. Brazil has this unique characteristic of having in the same location a huge variability of genetic landscapes. We have a very unique landscape here, which allows us to infer data about mutation. The beta amyloid pathway is one of the main pathways that we are studying right now, and it's very much associated with the African or European gene. We could study if that is deriving from regulatory markers of the epigenetic factors. This is something that we could study. I just wanted to congratulate everybody, and I have a question, Alicia. In one of your graphs, you showed that as the concentration of glucose increases and the liberation of insulin, maybe I read it wrong. The higher the concentration, the less insulin you saw, it was liberated, right? In the cells that are functioning properly, the more glucose, the more insulin is liberated. In the cells treated with obese women plasma, there was a lot of surplus insulin, insulin outside of the cell, which was not related with the amount of glucose. Because cells were literally bursting. They were no longer intact. They were liberating its internal content in a non-controlled manner. So the serum was making them ill by being inhibited by adiponectin. Patricia is right. She has an eye for inflammation, right? It seems like it must be an inflammatory process concerning women's serum. But these are things that we need to study. So the inflammatory cytokines, you haven't studied it, right? It's well known that obesity follows in an inflammatory state, and a lot of studies have looked at cytokines in that sense. We haven't in this study. So we don't have any more questions? I have some questions, but I will ask Sergio later. Once again, thank you to the three of you for the excellent talks. I will call up Prata and Glaucius to give us our closing remarks. So we don't want to hold you back any longer. We just want to summarize. We had an amazing 3 days for me and for Prata. This type of conference, on one hand, was very easy to do because these were in the afternoon and it wasn't a whole week. For sure, Jailson and others, they were able to exercise in the morning. And that combined with the possibility of watching such high-level talks, I believe it was very fruitful for all of us. So we went through environmental issues and given the importance to the preservation of our biodiversity, concerned with climate change, issues that are sometimes very simple but are also the most technological ones, which is already our future. We saw some 2050 data, but maybe in 2030 they would already be very important. In the second day, we saw the impact of advances that to us are revolutionary. I think the people who are growing up today see the changes in the information system, think that is very natural. I think it's very extraordinary. Computational systems being able to identify details in data, which is very hard to believe that very hard to believe that they would be able to be mined.
fósforos que algum dia já foram testados para malária, e de repente fez sistema de machine learning para tentar.
I had a student who created a machine learning feature for a very specific study, which was amazing to me. So these are things that we're learning how to deal with, and we heard about that on the second day, the impact of AI in our everyday lives, for bad and for good, right? And today, we had the gift of a very inspiring presentation by the WHO in the issue of COVID and the control and tracking of the pandemic.
Toca tanto, né? Nós que já, muitos de nós já se aproximando da melhor idade, temos aí estímulos, né, para que a gente possa ter perspectivas de.
And we have some stimulations to reach a productive longevity. I think this is the idea. Being old is good, but being old with a good computer working is better than anything. So it was a very pleasant session. Prata, the floor is yours now. I would like to echo Glaucius' words in the compliments to this session today. It is amazing. The 4 presentations were wonderful about all the aspects, about the clarity that the topics were approached, the depth and the consequence and importance in the best spirit that I think that is the meetings of the Brazilian Academy of Science. So we are reaching the end of our Magna Conference of 2022. It was a very peculiar meeting because we had, in a hybrid format, people in person here and people watching online. And those who watched and participated in the 3 days of the conference is surprised with the comprehensiveness and the importance of science. The consequence of the well-done scientific analysis and the hope that the science gives us when you look at the future, because it has been that way throughout our existence. The science is advancing, and the science allows us to enhance the way that we live in society. And it is showing us that more and more things are interconnected. In these 3 days, we had topics that at first are very different, but they are very much related. They are very current topics, and participating and watching the speakers and the events gives us a lot of ideas and stimulates us to our scientific activity and allows us to bring topics from one side to the other. And what we expect is that each one of us can continue defending the science unconditionally. Of course that we practice science from our perspective, from our area of work, but we need to defend the science, the Brazilian science and the advance of the Brazilian science in general on all of its dimensions. So it was very instigating and very encouraging to participate in this meeting. Especially I want to thank the opportunity to be here with Glaucio and Gerson and Mercedes and Boisson. We interacted a lot, we made a lot of meetings, we discussed a lot about people, about topics, And of course that we were surprised with the quality of the speakers. So we reached the end of our meeting. Glaucius suggested that we had a few acknowledgements, and I wanted to call Glaucius to make the acknowledgements to everyone who participated, especially the organizers and those who were behind, the people from the Brazilian Academy of Science, and all of them working very hard to make this event a productive one. If you allow me a final word, I'd like to suggest that the final word would be from our president.
Quem sabe, hein, Helena? Mas o Glaucio, acho que enquanto a Helena vem vindo, o Glaucio quer dar a palavrinha final.
Acho que é importante, Helena. Eu queria agradecer também as meninas que, ao longo de todo o evento, né, nos apoiaram de todas as formas aqui, trazendo seus microfones, cuidando da gente, o pessoal do som, perfeito, nenhuma sessão, a menos de uma ou outra internet que engasgou, mas isso não é problema só nosso, né? O mundo inteiro tem essas dificuldades. Então, agradecemos a todos, ao Luiz pelo convite de nos ter liderado por 6 anos e por ter nos convidado para preparar essa reunião magna, que fizemos com muito prazer. Muito obrigado. Helena.
Antes da Helena fazer o fechamento, eu queria me juntar ao Glaucio nessa surpresa que eu tive, sobretudo no evento de ontem, que nós tivemos esse debate misto, né? Hoje as pessoas estavam aqui presencialmente e fizemos um belo debate, mas na reunião de ontem nós tínhamos 3 pessoas que estavam remotamente em diferentes lugares, né? E nós conseguimos fazer um debate aqui muito perfeito, certamente pela competência do pessoal aqui que nos auxiliou, e me junto ao Glaucio aí no agradecimento a todos aí. Por favor, Helena.
Obrigada. Bom, eu só tenho que agradecer a gestão do professor Luiz Davidovich, que foi fantástica. Foram 6 anos de uma diretoria incrível. Eu tive a honra de trabalhar com o Luiz nos últimos 3 anos, na última gestão, onde aprendi muito. Os membros da diretoria foram fantásticos e foi essa diretoria, da qual eu fiz parte, mas sob a batuta dele, que nós chegamos a essa reunião. O futuro é agora. E eu estava dizendo, em relação, né, aos pontos que foram colocados por vocês hoje, como também ontem e anteontem, é uma pena. Eu vou recomendar, ontem nós tivemos o ministro aqui, né, Luiz, e nós vamos continuar tendo reuniões com ele, dizer para ele assistir claramente às palestras, porque ali, se ele tinha alguma dúvida de como projetar o ministério do qual ele está sendo cabeça, ele já tem 3 grandes temas, né? E aonde investir os recursos, porque está muito evidente que nós temos a preservação, né, a sustentabilidade, que a gente até colocou ontem, que o sustentável do governo não é o nosso, né? Essa que é a realidade. Então, tem que investir na biodiversidade, tem que investir nos costumes, nessas pautas todas, dos saberes tradicionais, que aquilo me impressionou, realmente, foram 3. Aí, a palestra de inteligências artificiais, quer dizer, foram fantásticos, sem comentários, e hoje o show de bola, né, sobre a saúde. Então, já temos aí, não precisa, Luiz, fazer mais nenhum levantamento daquele projeto que ele quer e contratar CGE, etc. Nós já temos aqui 3 coisas para colocar na nova Estratégia Nacional de Ciência e Tecnologia, mas com muito dinheiro. Porque enquanto a gente ficar lá com aquele dinheirinho
todo mundo se matando por causa do dinheiro do FNDCT, não vai dar. Então, parabéns à academia, parabéns ao Glaucius e ao Prata, foi uma reunião incrível e eu acho que nós temos que fazer uma divulgação desses vídeos, dessas palestras. Sair porque eu sei que as pessoas assistiram online, mas a gente pode ter uma repercussão muito maior. Então nós temos que... Depois eu tenho uma pergunta para você, Sérgio. Eu ia te perguntar como é que fica a insulina que vocês estavam trabalhando inalatória. Você vê que ainda, plástico não adianta, né? Mas é isso aí, eu encerro de novo. Uma salva de palmas para o Luiz, que foi quem fez essa reunião. O sucesso é teu.